Thank you. Well, good afternoon, good morning, everybody who is here. We hope that others will join as the hour continues. For those who don't know me, I'm Dr. Traci Downs-Bouchard from Nationwide Children's Hospital at Columbus, Ohio, and part of the Global One Health Initiative team and part of the Summer Institute for our lecture series. And I'm here representing Pediatrics and proctoring our pediatric portion of our Summer Institute. And I'm really excited to introduce one of our professors at our hospital, Dr. Nicole O'Brien, who's one of our critical care medicine specialists here at Nationwide Children's Hospital, who also works abroad and has been working in sub-Saharan Africa for nearly 15 years. She spends about 6 months each year of her clinical time there doing research funded by the National Institutes of Health. Her current research is generally focused on novel diagnostic and therapeutic approaches for children suffering from severe malaria, which is a very interesting topic that we hope to talk about at another time. But today, as a critical care specialist, boarded in both adults and children, Dr. O'Brien's going to talk to us about acute kidney injury from a pediatric focus. I'm going to mute myself for now, but I will be here to help with any questions. That if you have anything during the talk, feel free to either digitally raise your hand or type it into the chat box, and I'll be sure to get all your questions answered, and certainly at the end of the talk. Thank you so much, Dr. O'Brien.
Traci. All right, just confirming that everyone can see my slides. Yep, okay, great. Introduction, it's really nice to be with everyone today. And, you know, I think following that introduction, I think one thing that I've noticed at the bedside of children in sub-Saharan Africa is that increasingly we are recognizing the presence of and improving our ability to grade this acute kidney injury in children admitted to our hospitals for any number of reasons. And so over the last decade or so of providing clinical care on the continent, I've increasingly had an interest in acute kidney injury and how we can manage it in this setting. I apologize ahead of time. I have a little bit of a cold, so my voice is coming in and out, and I may cough, but hang in there with me. We'll get through it. All right, so we're going to first go through a brief case presentation just to get your wheels turning in terms of what your current knowledge status is following on acute kidney injury in this setting. And then we're going to review kind of the scope of the problem. All right, so our case presentation, you're admitting an 18-month-old female. She has a history of fever, headache, altered mental status. Her guardian says that it seems as if she's had some decreased urine output and some paraorbital edema. Symptoms have been present for 3 or 4 days. Her weight is 9.2 kilos, length is 88 centimeters, and her mid-upper arm circumference is 13. So no signs of acute or chronic malnutrition. Her malaria parasites are 3+. Hemoglobin is 5. You're fortunate enough to have some creatinine strips, and you are able to check your creatinine, and her creatinine is 3.2. And so with this in mind, you know, I realize we're not going to have a dialogue here, but start to think through what additional historical questions you might want to find out from this mother. So things that come to my mind, for example, are has this ever happened before? Before the onset of her current fever, her urine output seemed normal. Her urine color was normal. Did she ever have swelling in her face, arms, or legs previously? And then a lot of the chronic kidney injuries can be genetic or have familial causes. So, the other questions would be related to family history. Is there any family history of renal disease? Any family history of kidney injury? Things like that. And then treatment. So be thinking through like how you would approach this child at the bedside if you admitted them to your center next week. And I hope that by the end of this talk, how I would treat this kid will be clear. And then we can address any questions around her treatment if it's not at the end. Okay, so let's talk about the scope of the problem. The ISN, which is the International Society of Nephrology, now almost a decade ago in 2013, 2014, set out an ambitious goal. And what they said is they came up with this idea that was called the ISN 0 by 25. Which means they're looking for 0 preventable deaths from acute kidney injury by the year 2025. And so as part of that proposal, they did a global case prevalence study. So 74 different countries participated, and on 2 index days in the year 2014, each of these centers reviewed all of their inpatients and then relayed back to the ISN the frequency of patients with acute kidney injury that met their criteria for acute kidney injury, the cause and the outcome of those children or patients. So in that survey, on 2 index days, there were over 4,000 admitted patients that met the definition for acute kidney injury. We're focusing on pediatrics today. So you can see 354 were pediatric cases. Notably for us is more than 50% of the cases were from low and middle income countries. So there was a reasonable representation. And in that survey, both adults and peds put together, dehydration followed by hypotension or shock, infection, sepsis, and nephrotoxic medications, or some overlap of all of those causes, was the main reason that practitioners on those days thought that their patients had acute kidney injury. Notably, there was an overall 12% mortality rate in those patients that were presented to the ISN on those 2 days. This was another, and because that study was a little bit old, now a decade ago, we did another literature search recently and came up with this meta-analysis from 2023, where they looked at the incidence of acute kidney injury in hospitalized children. Defined as any pediatric patient less than 18 years of age. They included over 94 studies here in 26 countries, looking at over 200,000 hospitalized children. And when they looked at any incidence of acute kidney injury in these pediatric patients, the rate was 26%. And then when they looked at moderate to severe acute kidney injury, the incidence was 14%. Within that study on the African continent, there were over 10 studies that were included, over 4,000 participants. The incidence rate was similar, about 23%. And the overall mortality for the study as a whole was 11%, but highest between 18 and 22% in low and middle income countries. And the authors proposed this higher mortality was because of lack of resources necessary to appropriately diagnose and manage the complications of acute kidney injury in that setting. This is a look at, from that same study in terms of the frequency of the different stages of acute kidney injury. So you can see again here on the left, 26% had any degree of acute kidney injury. The vast majority of the patients, so 12%, had stage 1, or what we would call mild acute kidney injury. And then fewer kids had stage 2, 3, or 4, and all of those went together to form this moderate acute kidney injury. But you can see the stage 1 kids are those that are less likely to need actual interventions. But these stage 2, 3, and 4, which make up 14% of the overall incidence of the kids, are those that are most likely to have significant complications from their acute kidney injury and actually need some intervention. And so 14% of any patient population needing some significant intervention is a fairly high number, and something that we definitely need to be aware of as a complicating factor of pediatric critical illness. And then this is a forest plot. I'm not sure how familiar anyone on the call is with forest plots, but I really like them. I think it gives you a quick snapshot of a way to look at data succinctly. And so just to interpret a forest plot, this is a forest plot from all of the studies that were included in that meta-analysis that I just shared. The study names and their dates are here on the left. And then they looked at overall mortality, with increased mortality being to the right and decreased mortality being to the left in children admitted with and without kidney injury. So quickly, just looking down the board here, you can see that pretty uniformly, almost all studies showed higher mortality in kids with acute kidney injury compared to those without. Very few exceptions here. Here at the bottom, there's one, and there are a few where the confidence intervals cross that main line, which means it may not be statistically significant, but most are on this side. And for the meta-analysis, they dump all that data together and they come up with the overall value, and that's this red dot here on the right and that red dotted line that goes up and down. And so you can see the pooled data for all of their patients showed significant increases in mortality during hospitalization for those children admitted with who had acute kidney injury compared to those who don't. So that's just a quick look at how you might look at a forest plot to quickly get an idea of what the literature shows. Okay, so here we're going to move into a very brief review of renal anatomy and physiology. I think it's important to understand these concepts in order to fully understand how the pathology occurs in this disease. So the thing to keep in mind is that the kidney is divided into two zones. You have, let me get my pointer here, oops. So you have your outer renal cortex, which runs right here from the edge of your kidney down to about here. And that's where your nephrons are contained. And then your second zone of your kidney is going to be your inner renal medulla, which runs from about here down to here where your collecting ducts start. And your inner medulla is going to contain other parts of your system, including the loop of Henle, the vasa recta, and your distal collecting system. Importantly, there are approximately 1 million nephrons in each kidney. So you've got roughly 2 million nephrons that you're working with, but it provided you actually have both kidneys. This is a closer look at what I was just describing. So you can see on this cutout here, let me see if I can move this slightly so that no one can see. You can see on the cutout here on the edge, you've got your main nephron, your glomerulus here, which is in the outer cortex. And then you've got the other aspects of your kidney that are running here deep into this aspect of your kidney to form your complete nephron unit. And then this is just a closer up look at how that system comes together. So importantly, coming into every kidney, you have your afferent arteriole, and then that afferent arteriole forms a capillary network. And that capillary network is surrounded by a capsule, which is known as Bowman's capsule. And then the blood leaves through an efferent arteriole, which is here. It's most important to note that the diameter of the afferent arteriole is significantly higher than the diameter of your efferent arteriole. So that actually produces a hydrostatic pressure where fluids and electrolytes and other things are actually pushed out from the capillary into this Bowman's capsule and then proceed through the rest of the nephron for processing. But it's really just a hydrostatic pressure across that gradient between the afferent and efferent arterial that gets your renal system working. This is another look at that. So we have afferent arterial coming in. You hit your glomerulus. That's where glomerular filtration occurs. So water, solutes, and proteins are forced through. And then they head into the tubules. From there, then you can get some tubular resorption, particularly of water, glucose, amino acids, and things like that. While similarly, here in the tubules, you actually can get additional excretion. So not everything is filtered here. You get additional aspects such as hydrogen, potassium, drugs actually get excreted into the tubules themselves for clearance. And so this is another look at that, but when you look at all of the things that are getting filtered, that are getting absorbed, that are getting pushed into the tubules to reach their way to the collecting duct, I include it because it's important to realize when we think through the mechanisms of acute kidney injury that all aspects of the nephron, all the way from the afferent, efferent system, glomerulus, tubules, loop of Henle, and collecting ducts are important to maintain function, because if any one of those aspects is injured or not functioning properly, you're at risk of accumulating fluids, electrolytes, and so on, because it really does work as a complicated system. All right. This one more time. Oops. Okay, so together, I think of the kidney as having these following purposes. The first is to regulate blood volume and fluid balance. So essentially, your kidney, one of its main roles is to keep fluid removal going and to keep your net fluid balance even, so that you don't get periorbital edema, so that you don't get lower extremity edema, your fluid balance, and also so you don't get dehydrated. It also serves to regulate ions in the blood, so specifically sodium, chloride, potassium, phosphorus, and calcium. I think most notably we tend to see potassium and phosphorus issues, and then because of the phosphorus issues, calcium issues when kidneys are not functioning well. Your kidneys are going to regulate your blood pH because they excrete your hydrogen and force the body to hold on to bicarbonate. And so if your kidneys aren't working, you stop doing that and your bicarb will go low, your hydrogen will go high, and you will get acidotic. Kidneys excrete waste, so specifically urea and creatinine. I think we're all familiar with following levels of urea and creatinine as a marker of kidney injury. Your kidneys also excrete drugs. And then last, but I think something we don't think about that often, but is extremely relevant, is your kidneys actually make certain hormones that regulate specifically blood pressure. Many are relevant, but specifically we think about the renin-angiotensin system in this regards. And when you have renal failure, that system starts to dysfunction, and very often you will have significant hypertension in these kids that have kidney injury. All right, so what are the various etiologies of acute kidney injury in pediatrics in this setting? When I think about acute kidney injury, I think it's important to think through it in the following ways. So pre-renal causes, so things that happen before the nephron; renal causes, which is anything from that the Bowman's capsule all the way down; or post-renal causes, which is anything from the time it leaves the kidney all the way until the time where it leaves the body. And so common pre-renal causes essentially are anything that results in a poor perfusion of the kidney, where your pressure from your afferent vessel is decreased. So heart failure, sepsis, blood loss, dehydration, less commonly vascular occlusion, anything that decreases that arterial inflow to the kidney will eventually result in decreased clearance and decreased function of the kidney itself. Important renal causes globally: glomerulonephritis. You get inflammation of that glomerulus, those capillaries. Small vessel vasculitis. There are a lot of drugs and toxins that cause the tubules in the nephron to undergo necrosis. And then interstitial nephritis, or kind of an inflammation of the supporting structures around the nephrons themselves, are also common in the setting of various drugs, toxins, and so on. I think specifically in this setting, and it's not talked about a lot when you read global literature about intrinsic renal causes of disease, but these are all in this box I have here to the right, common things that we tend to see that are prevalent in the literature in our setting as additional causes of intrinsic renal failure. So malaria, HIV, tuberculosis, pyelonephritis, snake bites, hemoglobinuria, and then also trauma and hemolytic uremic syndrome. And then last is our post-renal causes. So these are typically obstructive causes. So anytime you have urinary calculi or stones, if you have scar tissue here, if you have any kind of malignancy in your genitourinary tract, in our pediatric patients, we always think of posterior urethral valves, particularly in the boys, where they get an obstructive nephropathy here. It's exceptionally important to recognize your post-renal causes of renal failure, because oftentimes, if they present in good time, if you overcome the obstruction, the renal failure itself will rapidly get better. And so a lot of these etiologies, if you place a Foley catheter, you'll see rapid improvements in kidney injury. And so if you can't do an ultrasound where you're looking for kind of bladder distension and ureteral distension, but you suspect kidney injury, I would highly recommend just putting a Foley catheter in to try and take any post-renal contribution out of what the clinical picture you're seeing, particularly if it happens to be a baby that's a boy, because of that posterior urethral valve risk. Okay, so this was when we start to look at etiology specific to our setting. Just moving this over here again. This was a study out of Cameroon. They looked at 103 kids that were admitted to their hospital. 87 of them met criteria for acute kidney injury. The rest had chronic kidney injury. So we'll just focus on the acute kidney injury. But about 60% of them, just under 60%, had acute kidney injury because of sepsis, which is typically your pre-renal cause or your poor perfusion, followed very closely by severe malaria and hypovolemia. Severe malaria we'll get to and talk about separately altogether. Hypovolemia will be the same pre-renal cause as sepsis. And then a smaller number that had diarrhea, hemorrhage, heart failure, and so on. I think what I wanted to draw attention to is in the kids with acute kidney injury in this study, they thought that dialysis was indicated in 40 of them, but only 27 actually received dialysis because of lack of equipment, lack of funds, or the patient passed before they were able to initiate dialysis. And then overall mortality in their kids with acute kidney injury was very high, much higher than the 12% that we saw in some of the earlier studies at 44%. This was another study with a similar number of kids in Western Nigeria, just looking at acute kidney injury at the significant tertiary center. Again, similar to what we had seen, 33% were admitted with acute kidney injury in the setting of sepsis, 12.5% with malaria, and then a smaller setting from a number of other causes. So if you're paying attention here, you'll see that in our setting, sepsis, hypovolemia, dehydration, and malaria seem to be the most common causes of acute kidney injury. This is a deeper look at malaria and its incidence from a meta-analysis that was recently done. Each site had used slightly different criteria to diagnose acute kidney injury, but you can see there's actually a vast degree of variance in the frequency of acute kidney injury. However, I'll point out that in a lot of the settings here, DRC, you've got 24%, Uganda, 35 to 45, Kenya, some of the studies were up to 14%. Sudan seems to be slightly lower at 7%. I didn't find anything on malaria in the Ethiopian region. I think it's less of a problem there, but you can see that malaria-associated acute kidney injury in this setting, in this region of the world, is actually quite high. So between 25 and 35% of kids admitted with severe malaria will also have acute kidney injury. I figured this was worth talking about briefly in terms of why malaria specifically causes acute kidney injury. So one thought is, and it is likely multifactorial. Also, one thought is mechanical. So infected parasitized red cells adhere to the microcirculation. And then they clump into rosettes and clusters, essentially causing microvascular occlusion, which decreases renal perfusion and results in acute kidney injury. We also know that those red cells that are adherent to the endothelium throughout the body, including the kidney, are highly inflammatory. And so you get activation of your inflammatory system. You may get some kind of immune complex deposition, end up with a glomerulonephritis type of picture and acute kidney injury. And then last is kind of this metabolic cause, which you have a lot of red blood cells that actually start to undergo hemolysis with treatment or because of the parasitemia itself. That results in the release of a lot of cell-free hemoglobin, and cell-free hemoglobin actually causes a lot of nitric oxide absorption, which results in vasoconstriction. And so you get vasoconstriction throughout the body, but specifically in the renal vasculature, you perfuse your kidneys poorly and get some acute tubular necrosis. And altogether, these result in acute kidney injury. All right, so we have now looked at acute kidney injury as it relates to the scope of the problem, the likely etiologies, as well as some of the basic mechanisms that we see. So how do we define acute kidney injury? How do we diagnose acute kidney injury? So a broad definition of acute kidney injury is essentially an abrupt decline in kidney function. Abrupt is not exceptionally well defined, but most people consider within 2 weeks of onset of symptoms, you present for care. So these are not kids that, when you actually talk to mom or you actually do their growth parameters, they actually look as if they're failing to thrive. Their growth is stunted. They've got other signs, they have significant anemia and other signs of chronic renal disease. But these are kids that out of nowhere were healthy and within about 2 weeks' time present for care because of acute onset of symptoms. And what are the symptoms that we're most likely to see? So decreased urine output is often associated with acute kidney injury. And I think probably in this setting, the thing that we see most often, parents will notice decreased urine output and they present with puffy face, puffy hands, puffy feet because of the lack of urine output. And then, of course, acute kidney injury is characterized by retaining of urea, creatinine, other nitrogenous wastes, decreased electrolyte clearance. Again, typically we worry most about potassium and phosphorus, and increased extracellular volume. Again, back to the tissue edema. All right, so this is a very busy slide, and we're going to go through each of these individually next. But there are a lot of criteria by which people typically try to diagnose acute kidney injury. And so I'm just going to mention each of them so that you have a comprehensive view of what is out there in the literature. So there's the rifle criteria. Then there is the pediatric rifle criteria. So if you've got an adult patient, a lot of times you'll talk rifle. If it's a pediatric patient, a lot of times it will be pediatric rifle. There's the AKIN criteria, acute kidney injury criteria. And then I think most recently you've got KDIGO criteria, which are really, I think, emerging as probably the favored criteria that people are discussing. Or using in discussions globally, and we'll get to the why behind that next. All right, so this is going to be your P rifle criteria. So rifle stands for risk, injury, failure, loss, or end-stage renal failure. And the definitions are here. This is not something you need to memorize. It's just something that you need to know exists. But essentially, to have risk, you're looking for estimated creatinine clearance decreased from normal or from a baseline by 25%. For those of you that need to remember how you estimate creatinine clearance, I included the formula down here on the bottom, which is 140 minus the age in years times the weight in kilos divided by 72 times the serum creatinine. And then if it's a female, you multiply by 0.85. Okay. So right there, you can see some of the issues with the P rifle criteria is it's a lot of math. And you also may not be likely to have a serum creatinine. And for these criteria, you're looking for both an estimated creatinine clearance decline and a urine output. Okay. So that's your P rifle criteria. I'm not going to spend a lot of time there because, like I said, people tend to be talking more based on the KDIGO criteria, which you can see here. It's a little bit more simplified in that instead of 5 groups, there's essentially 3 groups. There's acute kidney injury stage 1, stage 2, and stage 3. So that's helpful. Oops. The other advantage of KDIGO is that it is the same criteria for both a pediatric patient or an adult patient. So you don't have to look at the adult rifle criteria and the pediatric rifle criteria. You can just actually look at the KDIGO criteria for both a pediatric or adult patient and use the same criteria. So for these criteria, for stage 1, 2, and 3, things are listed here, but essentially, let's say stage 1, you're looking for a serum creatinine 1.5 to 1 times baseline or a 0.3 milligram per deciliter increase. And so on and so forth when you go from 1 to 2 to 3. I think we can all appreciate the limitations of this, which is we're very unlikely to know what any of our patients' baseline creatinine is. And this is particularly problematic in regions where malnutrition is an issue. Serum creatinine baselines will be significantly lower in patients that don't have a lot of muscle mass. And in regions where there is a lot of malnutrition, there's not a lot of muscle mass. And so a baseline serum creatinine typically is lower. And so not knowing where your patient started is a significant problem with these criteria, particularly if you have any suspicion at all that malnutrition might be at play because their baseline creatinine would be lower than the published norms. The advantage is you can also just look at urine output, and you don't necessarily have to use serum creatinine with the KDIGO criteria. And you're looking for urine output less than 0.5 mLs per kilo per hour for 6 to 12 hours for stage 1, less than 0.5 mLs per kilo per hour for more than 12 hours for stage 2. And for stage 3, I think it's difficult to differentiate sometimes between 0.3 and 0.5. So we're looking for the presence of anuria for more than 12 hours. And then that specifically meets some KDIGO criteria 3. And that one's typically pretty straightforward, even in the resource limited settings where you may not be able to monitor urine output closely. Typically, your parents will be able to tell you that you haven't had any urine output overnight, for example. I'm going to just skip that slide for now. But essentially, I think, these are just the challenges of diagnosing that I've kind of touched on already, which is all of the current definitions prefer the use of a serum creatinine. Again, typically our baseline is unknown, particularly for those with malnutrition. The thing I haven't said yet is creatinine is really also very delayed. So from the time that where you start to have decreased renal function, it actually takes at least 48 hours before your creatinine starts to rise. And so by the time you could certainly have a significant kidney injury, and don't see any increase in your creatinine for at least 2 days. And so if your child is arriving to the hospital early in their illness, and you have limited capacity to check a urea or a creatinine, your admission urea or creatinine could be essentially normal, but that kid is actually already having acute kidney injury, and it may be significantly elevated if you had an opportunity to recheck it at day 2 or 3, but oftentimes we don't have that capability because of lack of availability of lab tests or test strips or whatnot. The ability to use urine output is nice in terms of diagnosing acute kidney injury. However, I think it is very difficult to properly monitor in this setting. We don't put Foley catheters in most of our patients. Their nappies are not necessarily readily available, and so families are just changing contingency cloths or whatever they're using for diapers, and so it becomes difficult to actually assess the amount of urine output. So there are some real challenges. Um, Next, how do we manage acute kidney injury? So this is near and dear to my heart as a pediatric intensivist. I think we'll focus mostly on urine output, fluid balance, and electrolytes. So how do I manage it? So I have a patient that I suspect based on their history or their clinical exam that we've got acute kidney injury. The first is in this setting, when you actually already have a suspicion that acute kidney injury is present, you need to confirm definitively that you have low urine output. These are the cases where you want to use the limited resources that you may have. And these are the cases where, if possible, you want to catheterize those patients. So you suspect acute kidney injury because this is a child that came in with sepsis, and overnight the mom tells you that they haven't had any urine output overnight, or the urine output has changed in color. But put the Foley in that child. That's the right one, so you can actually more closely manage urine output. If you tend to see that you were having urine output and then it disappears, just double check and make sure that your Foley catheter isn't blocked. So give it a flush with 1 ml per kilo of sterile saline, and then commence a strict input and output fluid balance chart. A lot of times our nurses are too busy to actually do this properly. If you happen to have a guardian that can read and write, I will actually oftentimes give it to them and have them measure it and write it down every 1 hour or every 4 hours, depending. And I've had good luck getting at least reasonable ideas about where my urine output is that way. The other thing that you can do is you can get an appropriate body weight for the patient. So whether you have a standing scale or a hanging scale for the malnutrition clinic, a lot of times you can actually get the right body weight. If you see your weight going up, you are probably retaining fluid. If you see your weight going down, you're diuresing them appropriately. Then you want to obtain a urea and creatinine if you can, to get an idea of where you're at. If you can't, that's okay. If you've got low urine output, you're gaining weight, you've got renal failure. In that situation, I typically consider a furosemide challenge. So I'll give anywhere from 1 to 2 mg per kg of furosemide as a one-time dose, and then I closely watch urine output. If I get good urine output with 1 to 2 mg per kg of furosemide as the challenge, then I will continue that furosemide 1 to 2 mg per kg every 6 hours, and follow urine output from there. What else do you need to think of? So in these kids, most of the time you may not be able to check a blood gas, but you can typically know that they will have some degree of acidosis, or if you do check a blood gas and you see that they have acidosis. So if you know and they have acidosis, that's great. If you start to see patients that have renal failure that have some degree of acidotic breathing, it's in this situation, if you have it available, that I give IV bicarbonate, 1 to 2 MEQs per kilo, essentially. That will try and correct my acidosis. A lot of times, in this situation, again, if blood gas is available, I want to pay close attention to my ionized calcium level. And if ionized calcium is anything less than 1, I try to give IV calcium carbonate or calcium gluconate, depending on my access. Because as you give bicarb and you correct your acidosis, you're going to make your ionized calcium levels lower. And when your ionized calcium is low, you get decreased cardiac output, decreased squeeze, and you actually worsen your renal perfusion and can make your renal function worse. Not to mention your cardiac instability in the setting of electrolyte abnormality. Additionally, for acute kidney injury, you want to monitor and manage your electrolyte imbalances. Again, typically the potassium is going to be the one that we are most interested in because, of course, hyperkalemia can cause fatal arrhythmia. That's the other reason that I aggressively typically start a furosemide challenge. And if they have any urine output at all, I continue furosemide because your furosemide is going to make your kidneys waste potassium. And so even if you can't check electrolytes, if you're fluid overloaded and you start to make urine in response, you can assume that your potassium is high and that you're going to get some wasting of that potassium with your diuretic. So I typically continue. It's important to keep in mind that some of the other treatments that we use to treat hyperkalemia, such as albuterol, insulin, etc., they don't make your body waste potassium, they just drive it intracellularly. And so if you are able to check electrolytes and you are very hyperkalemic, in addition to diuretics, I certainly recommend albuterol, insulin if you can give it safely and monitor glucoses properly, and so on. Just keep in mind that those are just temporizing measures while you try and either make the kidneys waste potassium, make the gut waste potassium with some Kxalate, or prepare your patient for dialysis to clear your potassium. The other thing that you can typically do that is easy is put that patient on a low potassium diet. I have a printout of the low potassium foods that are available in the settings that I work and provide them to families. And sometimes it's very easy switches. So for example, less of the local cassava leaves and perhaps more of the local cabbage makes a significant difference in the potassium. But you can look at what you've got available in your markets and you can make your own low potassium diet forms that you can show to the patients so that when the families are looking for food, they can find those that are least likely to raise their potassium. I can't say this enough, again, because of the renin-angiotensin system. Hypertension is a huge problem for kids with severe acute kidney injury. If you have a pediatric blood pressure cuff and you're able to try and measure your blood pressure at least every 8 to 12 hours, particularly in that acute phase where the patient is getting sicker. If you are consistently more than 95 percentile for the age, you might want to think about initiating treatment for hypertension, at least in the acute setting. Calcium channel blockers, typically amlodipine is the most readily available and works well in this setting. The one thing to remember, you want to avoid ACE inhibitors, so anything that ends in tensin, because ACE inhibitors will actually relax your efferent arteriole, and so it decreases that hydrostatic pressure gradient that is pushing things through your glomerulus. So it will ACE inhibitors will acutely make your renal function worse. And then this is easy enough. I see too often we forget that we should discontinue and avoid nephrotoxic agents in kids that have acute kidney injury. So aminoglycosides are a known significant contributor to acute kidney injury, and we give those all the time. Same with vancomycin. A lot of time NSAIDs, so Brufen. These kids may be febrile from their sepsis or their malaria or their other etiology, and they're receiving Brufen for that. That's a very nephrotoxic agent. And so anytime I have a child at risk or who has acute kidney injury, I like to go through their medication list and make sure that we're getting rid of anything that we clinically can get rid of that might have any toxic effect, and switch it for something that has less of a toxic profile for the kidneys. You want to avoid contrast if they are in the hospital and need imaging, like a CT scan for something else, because it will make renal failure worse. And then I think I want to really draw attention to this, is if you have a patient who has had significant acute kidney injury and they start to get better with careful management and furosemide challenge, very often as their kidneys recover, they will hit a polyuric phase. So they will be going from anuric to low urine output, and then kind of out of nowhere overnight, you'll start to see urine output go up to 12 per kilo, 14 per kilo. It's because their kidneys are recovering, but they have lost still their concentrating ability. If you let them just be exceptionally polyuric, you will get a secondary kidney injury because of essentially hypovolemia and dehydration, and you can actually watch them go in the other direction. So if I see these kids start to get very polyuric, these are the kids that I want to keep up on their fluid balance. So I'll give the mom a cup, and for every time the child pees, they need to drink that much water so that they can try and maintain euvolemia. So just pay attention for that polyuric phase to make sure your kids don't rebound and have a secondary hit. And then just in the last few minutes of this talk, what about if, despite all of those interventions, we're still losing the battle? We still are fluid overloaded, we are anuric, we have hyperkalemia, and so on. This is when we need to think about initiation of acute dialysis. And in this setting, we're almost always talking about acute peritoneal dialysis. The mnemonic to remember about when you want to think about acute dialysis that I use is AEIOU. So acidosis. I typically use a cutoff of 7.15 as a degree of acidosis beyond which I want to think about dialysis. E is for electrolytes. Again, typically hyperkalemia will be the main driver. I is intoxication. Not that often seen in this setting, but there are certain drugs that you can dialyze off. O is fluid overloaded. So you've got a patient that maybe isn't that acidotic or hyperkalemic, but they're very puffy. You're starting to see respiratory compromise, tachypnea, and hypoxia because of the fluid overload. You may want to do that. And then U is uremia. Typically, the cutoff that's discussed to initiate dialysis is going to be a urea more than 200, primarily because of urea more than 200 induces both cerebral edema and platelet dysfunction and increases hemorrhage risk. So how do we do peritoneal dialysis? These two groups, so the International Society of Peritoneal Dialysis and the International Society of Nephrology developed this program called the Saving Young Lives Initiative. It was established back in 2012. Its first site was in Tanzania. They showed up, the International Society. They did a 2-week training session with local practitioners on how to do peritoneal dialysis. That was at the end of May, and that site in Tanzania first successfully peritoneal dialyzed a patient in July. And so since that time in 2014, this map here on the left is all the countries where Saving Young Lives has trained staff to work. There's over 285 clinicians that have been trained about how to do peritoneal dialysis. And that program has had significant positive effects. I'm just trying to move There we go. On outcomes. So patient outcomes, these are patients that had progressed essentially to anuric renal failure. So mortality in these kids previously was exceptionally high. And they saw 41% had complete recovery of renal function to normal, and then another 15% or so had partial recovery. And so overall, they saw 65% of patients survive without chronic renal replacement therapy. So these are kids that were supported acutely during the acute phase of their acute kidney injury, and they recovered and went on to live lives that did not require ongoing management of their kidney injury. I think the thing that is unique to this program is that they encourage improvisation. So they encourage whatever catheter you can put in the belly is acceptable in terms of initiating peritoneal dialysis. I've used all sorts of types of cannulas. I've used chest tubes that have been cut. I've used Foley catheters that have been cut to I've used IV tubing and so on and so forth. It's just important that you cut multiple holes throughout the side of the tubing so that you can actually get fluid in and get fluid out of the belly. The additional thing that's great about this program is you make your own dialysate. And so you don't rely on commercial dialysate, and you make your own dialysate. There's any number of ways to do it. I'll show you that in a table next. But essentially, you take Ringer's lactate and you pull off some of the fluid and you add 50% dextrose, and that gives you a dialysate that will have a high enough osmolarity that you pull fluid into the peritoneum and then you drain it through your catheter. This is available in the Saving Young Lives website as well as in the articles that they published. These are the different homemade peritoneal dialysis recipes that you can use depending on what concentration of dextrose you want. I personally typically use Ringer's lactate, and then if you want 1.45% dextrose dialysate, you pull off 30 liters and you add 30 milliliters and you add 30 milliliters of D50. I will often at the beginning start with a higher dextrose concentration to try and get improved clearance of volume and electrolytes. And so I will often do 50 or 60 mLs of D50, which gives me about a D2.5%. And that will give you more clearance up front. And then once you're ready to back off a little bit in terms of fluid and electrolyte removal, you can just change your dialysate and get the kind of clearance that you're looking for. So in closure, they say there was a recent survey to address, okay, according to the International Society of Nephrology, we're shooting for 0 deaths by 2025 in sub-Saharan Africa. And the survey was, are we getting there? Are we getting close? This is a look at all of the countries that were surveyed, their GDP, but I think to focus on this is the number of sites in these countries that were actually providing acute dialysis, which we all agree is an important part of reaching that 0 unpreventable deaths. And you can see they've got 20 sites in Nigeria, but really the rest of these countries, there are very few sites that are actually currently able to do peritoneal dialysis, and even fewer nephrologists that are able to manage them. And so, the conclusion was in the countries that were surveyed, there's really a limited ability to provide acute dialysis programs because of lack of facilities, funding, training, and so on. And so they felt that the ISN goal of 0 preventable deaths by 2025 is unlikely to be achieved unless we improve access to acute peritoneal dialysis through programs such as the Saving Young Lives program. And with that, I'm going to just close with acute kidney injury is common in African children for a number of reasons. We know that it increases mortality risk regardless of the etiology. But I hope that my talk was encouraging, because I do know, and I've done it many times myself, acute kidney management is possible in this setting through close observation of your clinical parameters and with the help of a few labs if you happen to have them available. Thank you so much. And with that, I will see if there happen to be any questions left in the chat for the last couple minutes.
Thank you so much, Dr. O'Brien. That was excellent. Really comprehensive, very informative, and very, very relevant. I do not see anything in the chat. I was love to open it up to questions now, though. If you're able to unmute yourself, I know some of you are muted by the host. You can. We have a minute, so please take your time. If you want to type something into the chat box, I'm happy to read it out for anybody. I'm sure there are some questions, and if we don't have time for questions, you can contact myself or one of the other hosts, and we will circle back with Dr. O'Brien and make sure we get any questions or comments discussed, because I think this is an interesting forum. We are recording all of these sessions as well, so that you can kind of revisit it and maybe have questions afterwards or comments, cases that you want to review. I know this must come up. It definitely comes up in my practice, and I'm not even an intensivist, so it's something we think about a lot. I think the reminder of the nephrotoxic drugs is a good one for all of us. I know ibuprofen is widely used as an antipyretic, and sometimes we don't think about it enough, and certain antibiotics. So I think there's one, just a lot of thank yous. Okay, it's what I see.
Yeah, I mean, I would encourage you. I think there's any number of information to read about acute kidney injury, but I would encourage you to familiarize yourself with the Saving Young Lives program. It does not require you to be a nephrologist. It does not require very much advanced care whatsoever. It just requires the idea that you can do it. And I probably once a month end up using peritoneal dialysis for some of these kids, and almost uniformly we get them through and they have great outcomes. And they come back in a few months and give us high fives and are going to live their lives. And so, I think that's some relatively unused management, but that doesn't require a lot of technology or resources to be successful.
That's very positive. There was one question about, I don't know if this is possible to answer in a minute or so, but differential if you have a patient with acute kidney injury and at the same time hepatitis.
Yeah, I mean, that one gets tricky, of course, because if you've got significant hepatitis, you're always at risk of hepatorenal syndrome. So when your liver stops functioning well, you typically get some locations you get vasodilation, other locations you get vasoconstriction. And so there's a common thing called hepatorenal syndrome, where you get dysregulated vascular tone to your glomerulus, and you can actually just get renal failure because of the liver failure. In that setting, it's quite difficult. The one thing that you can try and do, a lot of kids with liver failure tend to get fairly hypotensive, and most of the time you just let them be a little bit hypotensive because it's difficult to overcome. But if you're starting to see hepatorenal syndrome, you're going to have to probably drive their blood pressure up so that you can maintain your renal perfusion. So that would be the one suggestion, that you might manage those kids slightly differently than another setting. And then other than that, you're waiting for your liver failure to get better.
Very good. Well, gosh, thank you so much, Dr. O'Brien. I'm sorry that we have to move on, but
please have a great rest of your day. And looking forward to hearing how the rest of the educational sessions go.
Yeah, these are all recorded, so this is good for all of us. Thank you again, and have a great day.
You're welcome. You too.
Thanks. Well, thank you everybody for your time and attention. I know it's a busy afternoon. We're just going to move right along to our next lecture, which is very interesting and what I'm looking forward to. Something that we do see a lot in pediatrics, but is often tricky for those of us not geneticists to manage and diagnose. Our next lecture is going to be on inborn errors of metabolism. And we have dual team for this lecture, Dr. April Lehman and Dr. William Birds, who are both here at Nationwide Children's Hospital at Columbus, Ohio, as part of the Department of Genetics and Genomic Medicine at Nationwide Children's. And I'm going to hand it over to them. If you're able to unmute yourself, and you should be able to put your video on and share your screen, and I'll help you out in any way with questions that participants may have, or if you want any feedback from the participants. I will keep track of the chat box.
Okay, can you guys hear me?
Yes, we can hear you.
All right, well, my name is Will Burns. Oh, there's my video. Let me, I'm gonna kick us off, and then April's gonna take over our way through. You guys, what just happened? Can you guys see my screen?
Yes, we can.
All right, well, let us get started. So we are both clinical and biochemical geneticists, and so this talk is primarily on inborn errors and when to suspect and ways to manage some symptoms. We don't have any disclosures, and we have some questions here at the end. In terms of objectives, we want to help speak about some, how we identify IEMs that are associated with some acute, primarily acute, and some chronic presentations, identify some basic metabolic investigations, discuss treatment modalities and philosophies, and then discuss any available resources when you guys suspect an IEM. So some caveats. One, we both are biochemistry nerds, so we prefer to talk about IEMs. If you have also clinical genetics questions, we're able to answer those as well. But our preference is certainly inborn errors, just because we did the additional training. And then we are going to focus on conditions that have hopefully treatable symptoms, particularly quickly treatable. This talk is really going to focus more on acute, particularly neonatal conditions, or at least presentations, rather than some of the more chronic ones, just because it's hard to cover all of it. And then also, those are the ones where we tend to have the most impact early on. And again, this discussion is unfortunately not comprehensive, just because as of right now, I think there's a little over 1,000 different IEMs, and we certainly can't cover them all here. And then we wanted to focus on things that hopefully would be readily treatable anywhere. And then what are IEMs? So just real quick, so that we're all kind of on the same page, IEM is just an inborn error of metabolism. And so these are any inherited condition causing defects in metabolic processes. The first one was reported in about 1902. So that was alkaptonuria, which is an extremely rare condition. It was reported by a British doctor named Dr. Archibald Garrod. He reported a couple other IEMs before his retirement, and he probably reported the first handful. These are the criteria that we use for inclusion of a disorder into a kind of to be considered an IEM, because there are many genetic conditions where we found the pathways, and there's sometimes some confusion about when it becomes an inborn error and when it is more of a just a typical clinical genetic or general genetics disorder. But in general, anything that affects a metabolic process, so the breaking down of protein or carbohydrates, fats, those are the things that get included in IEMs. This is just a picture, because you can't have a presentation on IEMs without having at least one giant pathway shown. And so this is most of the most common pathways. It's particularly the ones that we deal with. This doesn't also not comprehensive. There are several dozen others probably that could show up on here, but this is just kind of a primer. And then this is a simplified one that I like to think about. So obviously we look at, most of the time we can break down things into protein, glycogen or glucose, and fat. And then this is a very simplified process of where each of these things end up as you break them down. When you think about acute onsets, these are These three macromolecules are the ones that present the most readily, especially in the neonatal period. So things like urea cycle defects, fatty acid oxidation disorders like medium chain acyl-CoA dehydrogenase deficiency, pyruvate dehydrogenase disorders, things like galactosemia and organic acidemias are the ones that we'll mainly focus on today. So these conditions are rare. Individually, most of these conditions are between 1 in 10 to 1 in 100,000. There are some that are much more rare. Collectively, they're considerably more common if you consider them as a group. And so some people say they're roughly like 1 in 5,000. Some people would say 1 in 3,000. I don't think there's a lot of great data to say one way or the other just how common they are. Mitochondrial disease has a bit more, and it's roughly estimated at 1 in 5,000. So if you include all the other ones, I would guess they're a little more common than that. And one thing we have to consider is every population we deal with has different kind of predisposing factors that make some conditions more prevalent. So founder effects. For example, I'm from South Carolina, and we had far more certain urea cycle defects because there was a small population in our state that tended to stay rather insulated, and they had a far higher level of something called arginosuccinic aciduria. Here in Ohio, we don't have quite as many as we had down there, but we have a far higher, for whatever reason, presentation of glycogen storage disorders. And knowing that, family history can be extremely helpful. So trying to find out whether a sibling's presented with the same presentation, what gender that sibling is to help determine what inheritance pattern it may be, whether there's been other infantile deaths or young children deaths, because some of these conditions don't always present the same even within the same family. So knowing whether there's just been any type of deaths in young childhood, and whether they were males affected, which we'll talk a little bit more about. So clinical biochemistry, so these are the kind of things that we think about, and just when we're deciding on how we treat things, the first question is, what is causing our problem? So typically a metabolic condition is caused by an enzyme defect between substrate A and B, causes substrate A to go up and the product to go down. A prime example of this would be something like PKU, which has the phenylalanine hydroxylase missing, which causes phenylalanine to go up and tyrosine to drop. And so this is what decides our treatment options when we think about this. So one option is to lower the amount of substrate A. So something like a low protein diet in a disorder like urea cycle defects, while also providing, if you can, the product that they need. So again, PKU is a really good example where we remove feed from the diet with either specialized formula or before formula was available, we would just give really low protein diets. But then we would supplement tyrosine if it was available. Nowadays, again, medical formulas provide a lot of that, but there are ways to do it without formula. Another option is to just go around the problem. So find an alternative pathway, and that can either be one that the body naturally uses, or it can be one that we create on our own. So an example of this is usually something like enzyme replacement therapy for mucopolysaccharidoses or Pompe disease, where we give artificial enzymes so that it makes A into B for the person. Those have limitations, much of which could be a whole different lecture. Another option is actually to provide a completely new pathway. So PKU, another prime example, there's a injection called Palynziq that's probably been available for the last 7 to 8 years. It actually provides a subcutaneous injection of a plant enzyme that breaks down phenylalanine in a completely different way than the human body is able to, that they then just excrete the products. And then the last one or at least one of the last ways that we can really influence something is by giving a whole lot of the cofactor. So that's typically a vitamin. Maple syrup urine disease is a good example in which some people are really responsive to thiamine. And we actually recently diagnosed a patient where really he just needs the vitamin and a very small or mild protein restriction, and his levels all completely normalized and improved. We often will use cofactor in almost any condition where it's able. We don't always see such fast and extensive responses, but in general, if you know that there is a cofactor, we'll try to take advantage of it. And now we're going to talk about some like red flags. Again, we've left these rather, I don't want to say bare, but general, just so that we have time for questions. And I believe someone else is having a presentation or may want to discuss a case at the end of our talk. So I will let Dr. Lehman take over from here, and I'm here for the slides.
Hi, everyone. Can everyone hear me?
Yes, we can.
Perfect. Thanks. So really, we're just going to go through some red flags now and what our differential diagnoses are. We did try to focus mainly on early presentations, so things that might be relevant for a NICU setting or a newborn nursery setting, or even early in infancy, as well as go through things that, things we can help treat in your setting. So one of the first ones we thought of as a symptom would be hypoglycemia. So one group of conditions where we see hypoglycemia present, whether you're sick or whether you are even just a well child, can be different fatty acid oxidation disorders. One of the most common ones here in the US is MCAD deficiency. So these kids tend to present with hypoketotic hypoglycemia. Usually they present during an intercurrent illness, or at least an intercurrent illness is exacerbated. So periods of times where we're using extra calories. So illnesses, if we have to undergo surgery for any reason, or our NPO for any reason. Prior to the advent of newborn screening, many of these kids would present as a SIDS case in late infancy. You get your first viral illness, you're just started sleeping through the night, and you kind of just been tipped up enough over the edge where you get that hypoketotic hypoglycemia. And so kind of without knowing the exact diagnosis, kids who have fatty acid oxidation disorders, they generally do best with frequent feeding. And then if they're acutely ill, we give dextrose fluids. So if a kid with either MCAD or VLCAD or whatever other fatty oxidation disorders comes to the hospital, whether it's a fever or a respiratory illness or a GI illness, we essentially support them in the hospital setting with IV dextrose until they're able to take a typical diet again. So for some kids, that's just bouncing back really quickly overnight. And for other kids, we're supporting them for a number of days. But generally, the child themselves is telling us when they're ready to get off fluids and go home by, resolving whatever illness they have and then picking up on their oral intake. Can we go to the next slide, please? Thanks. Certainly, depending on, another group of disorders for hypoglycemia would be our organic acidemias. Many organic acidemias, which is a very large group of conditions, usually presents in the first few days of life. So these kids can also be hypoglycemic, but the mainstay here of figuring out whether it's an organic acidemia, their ketones tend to be high. So this can be done with just a urine dip. We like to say that in the first weeks of life, having ketones in your urine or your blood is never normal. So if you see ketones, you have some type of inborn error where you need to be doing something about. So typically these are disorders in the amino acid degradation pathways. So typically, at least for our kids here, they're put on, for the most part, low protein diet, or if we know exactly what their disorder is, we're able to put them on specialized formulas that have that specific amino acid removed. So generally, we want to give these children enough protein to grow and develop, but without giving them too much that they get sick. So sometimes we have to sacrifice growth in order to keep the brain safe, keep the liver safe. Much like our fatty acid oxidation disorders, these children also tend to get IV fluids during acute illnesses. Many of them, depending if you have it available, also get IV lipids during acute illnesses as well to help support caloric intake. Many of these conditions, mortality is very high, even with specialized care, but certainly without specialized formulas and medications, mortality tends to be very high. Certainly though, there are a number of these conditions that you certainly can treat, especially the more mild presentations, where you can get away with low protein diet, IV fluids during illness, and do quite well. Another hypoglycemia red flag, hereditary fructose intolerance. It's quite rare, at least here in the US, but I think it's an important one to talk about because historically, hereditary fructose intolerance manifests when fructose or sucrose is added to the diet. So for many kids, it is their first experience with solid foods. The caveat to that being your many formula companies now are adding these to commercial formula products. And so these kids can present with hypoglycemia. They can present with seizures related to hypoglycemia. Sometimes, especially if they're older, they can present with chronic liver dysfunction related to small amounts of fructose or sucrose in their diet. The more mild kids who have this condition, they can fly under the radar for quite a long time before they're picked up. I follow one girl in clinic who wasn't diagnosed until she was about 4, which is a bit rare. But she naturally avoided sweet things once she started solid foods. So treatment for this condition is avoidance of fructose, sucrose, and their derivatives like sorbitol. Even those who have the best dietary compliance tend to have issues with both renal and liver dysfunction as they age. But certainly, this is one of those ones that can present in the neonatal period, can present, in the toddler or childhood years. There's also been reports of more mild adults who have presented with HFI. So something to certainly keep on the differential throughout the lifetime. Kind of changing things up a little bit, going through a combination of both hypoglycemia and hepatomegaly. There are a group of conditions that we see and treat who have hepatomegaly in addition to hypoglycemia, and that is generally the large umbrella of glycogen storage disease. Glycogen storage disease can present in multiple different ways, can present with hypoglycemia, can present with hepatomegaly. I followed one child who was actually had a heart murmur and was diagnosed because of her echocardiogram, which showed hypertrophic cardiomyopathy. And then someone noticed on exam that she had a big liver too. So for many of these kids, just like some of our other conditions, you want to feed them frequently. Giving a cornstarch equivalent. We typically use uncooked cornstarch here quite frequently in the US, but certainly whatever complex carbohydrate that you have available locally can certainly be utilized as well too. So most of these kids, they get sent home with glucose monitoring, whether it's a point of care glucose. Some newer technology we've been utilizing recently, which was not available in my training, was continuous glucose monitors. But certainly many of these kids will need overnight glucose checks, will need frequent feeding, complex bedtime snacks to maintain their glucose. Certainly glycogen storage disease is a diverse group. So certainly if we are able to, for example, we think the child has a glycogen storage disease, we're not able to really tell which glycogen storage disease we have. If we do have the ability at all to send out some extra labs, that could be helpful. Some of our glycogen storage disease kids just need that complex carbohydrate around the clock. Some of our glycogen storage disease, we know we could utilize other substrates. For example, glycogen storage disease type 3 has intact gluconeogenesis, and so we can give higher protein diets to those children, and they're able to utilize that to help prevent hypoglycemia and keep their hepatomegaly at bay. Another red flag category is hyperammonemia. Hyperammonemia can be due to a couple of different types of couple of different groups of conditions. So one of those groups of conditions are our urea cycle defects. So if our urea cycle is not moving along, you know, we're certainly building up our ammonia. And so I like to think of ammonia build up like a sink. And so we need to stop pouring water into the clogged sink, but we also need to get the water out. So generally kids who have urea cycle defects, we want to acutely remove their protein from their diet. We want to support them with high dextrose, IV lipids, if we're able to have that resource. Here in the US, we can use both IV and oral nitrogen scavengers. One thing that we weren't sure on whether or not you guys had access to where you're at is sodium benzoate. That is a type of nitrogen scavenger, but it's also used as a food preservative. So many countries have access to sodium benzoate when they otherwise wouldn't have access to sodium phenylbutyrate. Sodium benzoate works by conjugating with glycine. Glycine has one nitrogen. When benzoate combines with glycine, it forms hepuric acid, and that's excreted renally, and so you pee out your excess ammonia. Other nitrogen scavengers that we have conjugate with glutamine, forming compounds that are also urinary excreted in the urine. So that's one way to lower our nitrogen load, lower our ammonia, while we also support calories, anabolism, and temporarily holding off on protein. One of the most common, we go back a slide, 2 slides. We go back one more. Thank you. One of our most common urea cycle defects is OTC deficiency. OTC deficiency is one of our rare X-linked metabolic disorders. Most of the other metabolic disorders are autosomal recessive. So oftentimes when you're taking a family history and there's a concern for urea cycle defects, you can see early deaths for boys. You can see, many, near-term kids who have passed away, especially males. Even though it is an X-linked recessive condition, we do have many symptomatic females. And so even having a mom who presents, it's not uncommon to be, altered mental status during the delivery and early postpartum period. And that's when you get your urea cycle diagnosis at that time. So certainly urea cycle defects and hyperammonemia can present at any stage in life, starting in the first days of life, all the way through adulthood. Kind of going along that, organic acidemias, and also 2 fatty acid oxidation disorders that we already talked about. You can have secondary hyperammonemia because you're disrupting overall homeostasis. And so organic acidemias can also present with high ammonia if they are in an acute crisis or first presentation, as can fatty acid oxidation disorders. So many different conditions in your differential for a high ammonia level. Perfect. Another category would be liver failure, especially in the first week of life. One of the most common things that we think about that is treatable is galactosemia. And so galactosemia, there are many different ways to diagnose it, whether we're looking at enzyme, whether we're looking at downstream metabolites with galactose 1-phosphate. You can also do urine reducing substances if you have available. But the one nice thing about galactosemia is that you can easily treat this by providing soy-based formula. So if you're able to remove the galactose from the diet, you reverse the effects of the liver failure. Interestingly, one of the things associated with galactosemia is an early onset E. coli sepsis that can be seen in conjunction with kids with galactosemia. Another red flag is rhabdomyolysis, so very high elevated CK level. So this can certainly be seen at many different points in our kids with fatty acid oxidation disorders, but can also be seen as a later onset symptom. So if you have an older kid or even teenager, young adult who presents with recurrent rhabdomyolysis, so, muscle aches, dark urine, has a very high CK level, they might have a fatty acid oxidation disorder. It's not uncommon that some of these patients don't present until they're older children or even in adulthood. So much like our younger kids who present with fatty acid oxidation disorders, we want to also treat with frequent meals, low-fat diet. Certainly during acute illnesses, provide IV dextrose if available. And much like our younger kids, these patients cannot have IV lipids as well. Cardiomyopathy is a big one that can span many different categories as well too. So our kids with fatty acid oxidation disorders, as well as our kids with organic acidemias, they can present with cardiomyopathy, as well as, every now and then we have a glycogen storage disease patient who might present with cardiomyopathy as their presenting symptom too. So for many of these conditions, again, frequent feeding, IV dextrose, to help with their overall metabolic control. Lactic acidosis. So certainly there are many different things that can present with a high lactate. We like to say here in genetics that, if you have a newborn baby who has a high lactate, it's sepsis, 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 congenital heart defect, then hey, don't forget about us here in metabolism. Because certainly we can have a high lactate go along with many of our conditions, or at least be a presenting sign, a symptom with many of our kids when they are just metabolically not in good control. Certainly, there are many congenital lactic acidoses as well too. Many of them have a high morbidity and mortality, even with quick treatment. Treatment does vary with whichever disorder that you have underlying. Many of our congenital lactic acidemia kids, some do a lot better with high carbohydrate diet. Some do a lot better with a high fat, kind of more ketogenic diet. But our congenital lactic acidoses tend to have high morbidity and mortality regardless of treatment. Mitochondrial disease. Mitochondrial disease, thinking about mitochondrial DNA that's inherited just from mom. These require a high index of suspicion and are quite common. Sometimes family history is helpful, sometimes not. The hallmark of mitochondrial disease, essentially, I love this quote, is any symptom, any organ, any age, with really any mode of inheritance. So a lot of these tend to be our, older children, young adults, or even, older, middle-aged to older adults who present with many different symptoms. Going off of some recent literature, it seems like when asked about symptoms, the average person with a mitochondrial disorder has between 15 and 20 symptoms on a review of systems. So certainly something to think about, something to keep in the back of your head when you see a patient with a pan-positive review of systems, that they might actually just have a defect with their mitochondrial DNA. I know many of us were taught that mitochondria are the powerhouse of the cell. I prefer to think of them as a more of a cell battery. So if you think of a cell phone, you know, our ultra athletes are running at 100%. You know, most of us are running, you know, somewhere in the green, but those with mitochondrial disease, they might be starting out, you know, on low battery already. And so supporting those patients really depends on what they have underlying. But generally, mitochondrial disease is more common and it has a variety of symptoms. So certainly when to treat many of these conditions. So anytime you have a high enough clinical concern, or if there are labs that suggest one of these conditions, it's typically appropriate to treat. So making sure we have frequent feedings, IV dextrose for many of our conditions, certainly acute liver failure in the first weeks of life, especially if you have positive urine tests. Soy milk can be life-saving for these kids. At least here in the States, we have Newborn Screen that does a pretty good job at catching all of our kids with galactosemia, but certainly that is not the case elsewhere. Elevated ammonia is a medical emergency. So many of our kids, once they get a high enough ammonia level, we do have to treat them with dialysis, while we are also trying to figure out what their underlying condition is. So making sure to provide adequate calories with dextrose and lipids if available, temporarily removing their protein, which is their source for, can be one source for their high ammonia level, and then getting that ammonia level down to protect the brain will all be helpful to keep them to keep them well. We just had a couple of questions. Not sure if anybody wants to add in the Q&A section. So 5-day-old presents with E. coli sepsis and liver dysfunction. What should be highest on your differential?
Can't see the chat or anything, so just let me know when to.
We have one
It
answer
looks like
here.
somebody just wrote A. Yeah, so galactosemia. So early liver dysfunction, E. coli sepsis, those are both red flags for galactosemia. A 2-day-old presents with altered mental status and presents with a coma. He is in a respiratory alkalosis. What class of disorders would you consider? I don't think we talked about this specifically during that section, but ammonia is a respiratory irritant. So kids who have really high, kids who have really high ammonia levels tend to be tachypnic because it is a respiratory irritant. That being said, organic acidemias and fatty acid oxidation disorders can also present with ammonia as well too. Urea cycle defects, they tend to be significantly higher ammonia level, and they are not accompanied by the ketoacidosis that we see in our organic acidemias, for example. So yes, a kid with respiratory alkalosis, 2 days old, ultramethyl status is urea cycle defects.
2 days old is typically going to be more of a recycle defect than the other two, just too early.
A 3-month-old presents with a hepatomegaly and intermittent ketotic hypoglycemia. So the things that I would most likely consider in this case would be some type of glycogen storage disease. And so what would you recommend to treat this kiddo with? I see some varying answers in the Q&A section. I think this one's a little bit of a trick question because there certainly can be more than one right answer. So I would think that this kid, like I said, has some type of glycogen storage disease. So certainly frequent feeding would be a great answer for any glycogen storage disease. Certainly many of our glycogen storage disease, you can give uncooked cornstarch. Certainly you want to avoid the simple sugars for many of these. And then depending on your type of glycogen storage disease, sometimes we give extra protein, but for many of these kids, they need frequent complex carbohydrates.
This one is trickier. And uncooked cornstarch, I don't know if that was mentioned. The only reason that's not correct is because of the age of this patient. So we really can't use uncooked cornstarch until the age of at least 1 reliably, because the liver is not mature enough to break it down sufficiently.
Do you want to take over?
Oh yeah, sure. So here's some resources. The WHO has, this is maybe a line that you guys are already aware of, but certainly can help with some of this. Highly recommend having 1 or even 2 people maybe reach out about what's called MedTab-L. So this is a worldwide listserv of a lot of geneticists, mainly biochemical. So its focus is metabolic disease or inborn errors. You would just need to reach out to Dr. Renner. He's out of Europe. Just send him some info, and I don't think anyone would have an issue being added. Gene Reviews is a resource that's published on PubMed and is an expert. They're all expert and curated articles, generally getting updated fairly frequently, at least once every 5 to 7 years. I know me and April will both use them frequently. I think every geneticist does around here. So they're a great resource. And then this link on the bottom for what's called the Vademecum Metabolicum, which is, I know like infectious disease has the red book, and this is our yellow book, which is a comprehensive metabolic kind of treatment and information. Unfortunately, the online version is only the 3rd edition. We're on the 5th edition now, so it's a bit outdated. Not terribly so. I was looking through it earlier. Some of the dosing is a little outdated. We don't typically do as high dosing for some of the things, but still a good resource. And then also feel free to reach out to us. I know we both get emails frequently throughout the day from around the hospital, and oftentimes both of us will weigh in if there's a question about a metabolic condition. And just in case anyone is saying what is going on, it is open to questions. I'm going to stop sharing just so I can see things.
Thank you guys both so very much. That's a lot of information that you were able to accomplish telling us about in a relatively short time. I liked the way that you presented it with the red flags for those of us who are not biogeneticists. All of those pathways and different categories are often hard to memorize, but it's good to think of it as how a patient would present and then working from there. So that was a very, very helpful review. We do have time for questions. I know that some of you may be muted. You can feel free to type into the question or the Q&A box or the chat. We have some time that I'd be happy to read out your questions. Or if you don't get to it in time, all of the lectures are recorded, and I can also send emails to Dr. Burns and Dr. Lehman after the fact if you had a case you wanted to discuss or a specific question we did not answer now.
Hello. This is Peter.
Hi, Peter.
Yes, hello, Doctor. Thank you very much for the moderation, and thank you, facilitator. Basically, I would love to ask you 1 or 2 questions. What ethnic groups are at risk for metabolic syndrome? And that's the first question. And then the second question is alcohol a risk factor for metabolic syndrome, especially for pregnant mothers during the prenatal period? Can we get worried that if someone is a heavy drinker of alcohol, probably the baby could suffer from the inborn errors of metabolism. Thank you very much.
So I just make sure, it sounds like the first question was who would be at risk for an inborn error?
Like what ethnic groups at a greater risk for metabolic syndrome? Yes.
So, and April, you're welcome to weigh into most of our metabolic conditions are what are called recessive conditions. So any groups where they tend to be they tend to stay in a smaller area or more insulated groups of individuals. So, for example, here we have in Ohio, like the Amish and Mennonite populations who tend to stay within their own community and marry within the same community. They would be at higher risk just because that would make both parents at higher risk of being carriers of the recessive condition. But also, I would say there's also just a general risk for all people just because because they are recessive, the parents can be carriers and not realize it. Just know that risk is higher if they are closer in family relations. So even out to second, third, fourth, fifth cousins, things like that would place them at higher risk.
Yeah, I completely agree. There isn't one particularly ethnic group that would be more susceptible or less just overall, but certainly smaller populations, more consanguineous populations, whether it's due to geographic or social constraints, can certainly have a higher risk because of the recessive nature of many of these conditions. It sounded like the second question was about prenatal exposure to alcohol. Certainly we see many children in general genetics clinic who have had fetal exposure to alcohol. Certainly there is a spectrum to that, but our kids who are most affected tend to have neurodevelopmental differences. They tend to have poor growth compared to their peers, so shorter stature, trouble gaining weight. They can have differences in their facial appearance as well too, and they tend to struggle with learning and development over time. So certainly our children of mothers who are the heaviest drinkers tend to suffer more, but certainly there is a spectrum there. So even if someone doesn't meet necessarily criteria for fetal alcohol spectrum disorder, there can be fetal alcohol exposure that we see. In addition to alcohol, we see some medications, especially here in Ohio, there's a big fentanyl epidemic. And so certainly we see some both growth and neurodevelopmental and some metabolic mimics of our conditions due to exposures to high and frequent fentanyl exposure, for example. But certainly there are many teratogens that can cause lasting effects in a neonate.
Of any teratogens that would increase your risk specifically for an inborn error, those are typically just down to the DNA level. So it's just dependent on if mom and dad are carriers or if the baby has a de novo or spontaneous change in the gene.
Thank you so much. That was fascinating. Any other questions at the time? I know there's a lot of thank yous, which I agree. We do have an evaluation for all the speakers, so please don't forget to fill it out. We'll include it in the chat as well. I really thank you guys so much for your time. Yeah, it was very interesting. And if any other cases come up from our participants, I will be sure to share it with you. Those resources were also very helpful.
Absolutely. And you guys are always welcome to reach out to us. We're more than happy to help answer questions.
All right. You guys have a wonderful day. Thank you so much again for your time and your expertise. Okay. Thank you.
Bye.
Yeah. And yeah, if we can include the link again for the evaluation for these speakers, that would be so helpful. If one of our hosts or panelists can do that, that'd be great. Our next speaker, who I'm not sure if is on the line yet, is Dr. Amanda Weber. Dr. Weber, are you here today? I'm going to check our, not sure if she's here yet. Well, I can send her a message, make sure that she got the link and that it is working correctly. Thank you guys for your patience. I know we have a early morning schedule here in the US, so thank you, Dr. Weber, for being here with us. Take your time. We're just
Hi, good morning.
transitioning over to your
Oh,
lecture.
okay.
Thank you.
Great. Yeah,
well,
I was on earlier today and we practiced screen sharing. So hopefully this will work. Let's see.
Yeah. Dr. Weber is going to be speaking to us today on epilepsy in childhood. She's also one of our assistant professors here at Nationwide Children's at Columbus, Ohio, and she is a published researcher in the field of child neurology and has a special interest in medically refractory epilepsy and underserved populations. We're so privileged to have her speak on this topic. I know this was one of the topics that was suggested. So I'm going to turn over to her, but again, feel free to ask any questions, or if you have any comments during the lecture, you can just put it in the chat box and I will speak on your behalf. Thank you so much.
Thank you very much. Are you able to see my slides?
Yes, we are.
Perfect. Okay, then I will start here. I'm sorry my video is not sharing. I'm not sure what's going wrong there, but I'll just proceed. I'll just go ahead. So today we're going to talk about epilepsy in childhood. Having trouble advancing here. Okay. So the objectives are, I'm going to start by talking about the definitions of seizures and epilepsy and refractory epilepsy. We're going to talk about the first time seizure workup and evaluation. And we are going to watch some videos, hopefully, I'm hoping that they work, so that we can learn to recognize some important seizure types in children and talk about the treatment options. I was asked to talk about epilepsy syndromes and some of our management techniques for refractory epilepsy. That's a lot to put into one talk. And so I kind of picked a few that I thought would be interesting and would demonstrate some of the tools that we use to help work up and manage refractory epilepsy. So here's an outline of what we'll start with. We'll start with definitions and talk a little bit about epidemiology and basics of seizure evaluation as the first part of the talk. And that's going to be kind of the more boring part. And then we're going to switch to a case-based format where I'm going to cover some of the epilepsy syndromes and some more of the management options and workup. So starting with the basic definition of a seizure is a transient occurrence of signs or symptoms due to abnormal, excessive, or synchronous neuronal activity in the brain. What that basically means is that there's abnormal electrical activity in the brain that all synchronizes, all happens kind of at the same time, and results in a set of signs and symptoms. So here's a picture of 3 Hz spike wave discharges that we would see in a typical absence seizure, where a child is staring, having behavior arrest, and things like that. So when we talk about epilepsy, epilepsy is a clinical diagnosis. So you don't have to have any abnormal test at all to have a diagnosis of epilepsy. The EEG can be normal, the MRI can be normal. It often is not, but it can be. And so epilepsy is really a clinical diagnosis that we make on the basis of clinical history. And so the International League Against Epilepsy, the ILAE, defines epilepsy in a couple different ways. The first way is 2 or more unprovoked seizures happening at least 24 hours apart. And we know that the risk of ongoing seizures, if that happens, is high, is more than probably 70 or 80%. And so at that time, we typically would recommend to start management or a medication for seizures. The other time that we diagnose epilepsy is if there's a single unprovoked seizure, but a high probability of further seizures. And so one example of when that would come up is if you have a single unprovoked seizure, but then you have testing to suggest that the risk is high, or that there's a diagnosis of an epilepsy syndrome as a result of that EEG. So one example of this would be in self-limited epilepsy with centrotemporal spikes. In the past, that's been referred to as benign Rolandic epilepsy or epilepsy with centrotemporal spikes. This is a really common epilepsy syndrome that happens typically around early childhood, and typically consists of focal seizures out of sleep that typically involve the face pulling to one side, some numbness, tingling on that side of the face, and then you may have jerking of the face and or arm on that same side. And so if a patient presented with a single unprovoked seizure, we did an EEG and found the characteristic pattern of centrotemporal spikes on the EEG, then that patient would be diagnosed with epilepsy, even with just one seizure, because of the epilepsy syndrome that we could diagnose based on the EEG. Resolved epilepsy. So this is in people who have a history of epilepsy, but the epilepsy, they've outgrown the epilepsy, or the epilepsy has otherwise resolved. And so we would diagnose this, or we would tell that somebody has a resolved epilepsy in individuals with an age-dependent epilepsy that now they're past the applicable age. So for example, with that self-limited epilepsy with centrotemporal spikes, almost everybody with that outgrows the syndrome by the time that they're in their mid or late teenage years. And so in that case, if that person's now 25, hasn't had a seizure in quite a while, then we would call that resolved. Another time that we would call epilepsy resolved is if individuals have remained seizure-free for at least 10 years and off of anti-seizure medications for at least 5. So moving on to the epidemiology of epilepsy. So epilepsy is extremely common. It's one of the most frequently occurring chronic neurological conditions in childhood. 0.5 to 1% of children have epilepsy. We see the highest prevalence in infancy, and when we look at epilepsy in general, people with epilepsy in general, most of them, the majority of people, will respond to the first or second well-chosen medication and do have the possibility of being seizure-free on the first or second well-chosen medication. But that leaves a third, or about 30 to 33%, who remain medically refractory despite medications. And we'll talk more about that later. So etiology varies by age and by region, but we kind of think of it kind of in thirds again. So we can find an etiology in about 2/3 of patients. And as our genetic testing is improving, that number is probably increasing. So about 30% will have an underlying genetic cause. excuse me, that we can identify, and about 30% will have a structural cause. And some structural causes are things like malformations of cortical development, so things like cortical dysplasias. And you can see that here in this picture. This patient has a left temporal cortical dysplasia, and you can see on this T2 MRI in a dark area, kind of in the left temporal area. So that is the area of cortical dysplasia. And then you can see just kind of blurring of the gray-white junction in that area. So that's an example of a structural lesion that we could see in somebody with epilepsy. Other structural causes would be things like vascular malformations, hypothalamic hamartomas, traumas, perinatal insults. So this could be things like hypoxic ischemic encephalopathy, and the changes related to that. This could be strokes or glioneuronal tumors. And then the other smaller group are things like infectious inflammatory autoimmune causes or metabolic causes. So when we think about a first-time unprovoked seizure and workup and diagnosis, this, I just want to point out, we are going to be talking about ages about 1 month to 21 years. So we're excluding neonates. And the reason for that is because neonates tend to have their most common seizure type is electrographic only. So you tend not to see them as much clinically, although they can have clinical seizures. And the most common cause of seizures in neonates are acute provoked causes. So things like hypoxic ischemic encephalopathy, strokes, infections, different things like that. And so that is kind of a whole talk in itself, and we're not going to talk about that today. So we're really going to focus on children 1 month to 21 years who have their first unprovoked seizure. We're also excluding status epilepticus, so prolonged seizures, seizures lasting more than 30 minutes, and febrile seizures. So the first step in working up a first unprovoked seizure is taking a detailed history and physical. And so our main point in all of the questions that we're asking now is to try to figure out, is this a mimic or is this truly a seizure? And if it is a seizure, what type of seizure is it? And is this child otherwise at risk to have seizures? So we ask a lot of detailed questions about the semiology. We want to know exactly what the parents or the caregiver or the witness saw. And we want to know kind of the sequence of events too, because that tells us kind of what parts of the brain were affected first. And so we would ask questions like, did it start in just one part of the body or did it start in the whole body at once? I would ask questions about which ways were the eyes looking? Was there any kind of gaze deviation to suggest focality? Was there any kind of aura preceding the seizure? And in little kids, it's very, very tough. A lot of times we don't get any history at all of aura, but sometimes you can infer it based on their behavior. So sometimes a young child would run to their parents or sit down or lay down even before a seizure happens because they know it's happening, or they know that it's about to happen. And so just kind of getting that history of how do they act right before can be really helpful to tell you that maybe there is some focality, maybe there is an aura before it starts. Eyes, so we mentioned gaze deviation as a possible sign of focality, but the other thing that we look at with, and that we ask about with eyes is when we're trying to distinguish non-epileptic spells from, or psychogenic non-epileptic spells from seizures. Eye closure, especially forced eye closure, is one of the things that is much more highly suggestive of psychogenic non-epileptic spells. And so that's usually something that I'll ask about. It's uncommon to have eye closure, especially forced eye closure with an epileptic seizure. The symmetry we talked about, and the reason for this is we are wondering about focality and seizure type, duration, how long did it last, and then has it happened before? And that's important because remember, our definition of epilepsy is a clinical diagnosis. And so we need that history. If they've had multiple similar events, then even the first time they present, you can probably diagnose epilepsy if it's happened many times before. So other details that we would want to know, development, especially things like, are they meeting their milestones? Is there any kind of asymmetry in their motor development? An early hand preference before 2 years of age is abnormal and would make us think about some type of structural lesion that could contribute to early handedness, and that could be something like a stroke or a cortical malformation. We want to hear about birth history to know if the child was at risk for hypoxic ischemic encephalopathy or any type of damage to the brain, gliosis, things like that, that could contribute to a risk for seizures down the line. And then thinking about medical history, especially family history of other seizures or febrile seizures. That's an important thing to ask about because in families with a strong family history of febrile seizures, sometimes they have something called GEFS plus, which is generalized epilepsy with febrile seizures. And so they can have seizures with and without fever. And sometimes those are the result of a sodium channel mutation. And so even if the seizure looks focal or is a focal seizure, sometimes they can worsen with some of our focal seizure medications like oxcarbazepine, carbamazepine, lacosamide. And so we would avoid those typically in kids who have a very strong family history of febrile seizures and maybe who themselves have had a history of febrile seizures. Other things to think about would be head size. Are they microcephalic? Are they macrocephalic? And what is their neuro exam? And with neuro exam, one of the other things that we always focus on is the skin exam. We look carefully for neurocutaneous markers, so things that could be suggestive of tuberous sclerosis, for example, which we know has a high association with different seizure types. The other thing we ask about are provoking factors. So we want to get a very good history about history of trauma, any kind of toxic ingestion, any kind of risk factors for electrolyte abnormalities like hypoglycemia, anything like chronic vomiting, diarrhea that could put them at risk for electrolyte abnormalities, and also kind of a persistent encephalopathy. So some of the tests that we would consider if we were to get the appropriate history is we may consider checking electrolytes, glucose, tox screen, a lumbar puncture. But we have guidelines from the American Academy of Neurology about first time unprovoked seizure workup. And all of the studies that have been done have shown a really low yield for routine lab testing in kids across the board who have a first time unprovoked seizure if they've returned to baseline. If they're back to baseline, the seizure was short, and they've kind of returned to themselves. And so we don't routinely get a specific lab panel on every child with first unprovoked seizure. So, and again, things that we would look at would be for glucose, hyponatremia, hypocalcemia can all be potential triggers. So this is the first thing that I was hoping to get some input on. So I'm hoping that you guys can use the chat and just weigh in. So this is going to be a video that I'm going to show you guys of a spell type. So somebody came into the office and said, my kid is having these shaking spells. The child is 1.5 years old, and she's having events of full body shaking and trembling with retained awareness, and they're occurring many times a day. She has no loss of tone. She doesn't fall with these, and they're typically happening while she's in a high chair eating, kind of around that time. She otherwise is normally developing and has a normal EEG. So I'm going to play the video. Can somebody chime in? Were you able to see that video play?
Yes, it was brief, but yes.
Perfect. I'm going to play it one more time. So see just that little kind of shiver. Does anybody have any ideas about what that spell is? Is that a seizure? Is it not a seizure? What do you guys think? Let me see if I can. I don't even know if I can see the. Oh yeah, here's the chat. Let's see.
I don't see any answers yet.
No answers. Nobody brave enough or awake enough. So it's not visible. So absence
Absent.
epilepsy. Okay, so good thought. I'm going to play it one more time. Okay. so that hopefully somebody else can see. Thank you for everybody who's chiming in. I really appreciate it. It does not matter if you're right or wrong. That's why we're doing this. So see that little tiny shiver there.
Is that a myoclonus, maybe?
So it kind of looks myoclonic. Okay, so that's good. Okay, so this is actually a benign event. So this is one of those mimickers. Okay, so this is a benign shuddering attack, and we see these very commonly in kids, starting usually around 4 to 6 months of age. There's often an association with eating, and it looks just like that. It looks like a little kind of non-specific shivering type movement. Sometimes the kid will have deviation of their head or eyes. Sometimes they'll have, like you mentioned, a little bit of a myoclonic component to it. It almost looks like there's a little bit of jerking with it. They can occur several times a day, and they're really, really short like that. And the kids are typically developmentally normal. EEG is normal. If you image them, it's normal. And they outgrow these by 4 years of age, typically. Sometimes there's an association down the road with a benign essential tremor or family history of benign essential tremor. And so, that's something to keep in mind, but you don't have to treat these. And so, getting a video from parents to kind of help see what they're seeing can be very, very helpful so that kids are not kind of inappropriately diagnosed with epilepsy. And so this is just kind of a list of differential diagnosis. So when we're taking that history, these are some of the things that we should be thinking about and trying to exclude or trying to, at least consider when a child comes in with a strange event. And so jitteriness is something that we typically see in a young baby. And sometimes maternal exposure to things like SSRIs or certain medications can put a child at higher risk to just be generally more jittery or twitchy when they're first born. Sometimes electrolyte abnormalities, hypoglycemia can be associated with jitteriness or dysmaturity. Hyperexplexia is an exaggerated startle reflex syndrome. It typically has a genetic basis. There are a couple different genes that can be associated, and it's caused by a problem with glycine neurotransmission. And so this is typically treated with clonazepam, but a lot of times these kids are misdiagnosed as having epilepsy, and typically they have a really exaggerated reflex in response to a loud sound or something like that. Benign sleep myoclonus, we can see in young infants, and these can look almost like repetitive clonic jerks as the child is falling asleep. Benign shuddering attacks, that was one example that we just saw, which are kind of shivering like movements. Sandifer syndrome is another tricky one that sometimes these kids come in to rule out infantile spasms because these kids can extend their backs or they can posture and they can make kind of funny faces during these. And so Sandifer syndrome is just discomfort related to reflex that causes them to move in funny ways. Spasmus nutans is a syndrome where children develop nystagmus, head bobbing, and funny neck movements. And they're typically benign. They go away with time. But we do typically image these children because there's a rare association with some types of masses, especially around the optic chiasm. Paroxysmal tonic upgaze is another thing in our differential. With these events, kids tend to flex their neck so their chins kind of point towards their chest, their eyes look up, and then they get some vertical nystagmus or downbeating jerks of the eyes. Sometimes it can be associated with episodic ataxia. It can look worse during febrile illnesses, but typically benign. And EEG is negative during the events. And I think up to 40% of these kids can have associated developmental delays or cognitive deficits. So that is something to kind of be aware of and watch. Parasomnias are sleep-related things that can mimic seizures, breath holding attacks. Of course, one way to distinguish these is they should always be associated with kind of crying or some type of upsetting event happening before before the child loses tone and kind of has a syncopal-like event. These can be associated with a low serum ferritin, so sometimes using an iron supplement can help improve these. There are lots of movement disorders that can mimic tics or can mimic seizures, things like tics and stereotypies and dystonia. Stress-related disorders, so psychogenic non-epileptic spells. And these videos are really, really helpful so that you can look for some of those little things. You can look at the eye closure, you can look at the rhythmicity of the jerking, you can look at the focality. A lot of times with psychogenic non-epileptic events, the people will present with kind of like a pelvic thrusting type motion. And so just being able to see that on a video can be very, very helpful. Syncope, migraine, vascular issues like TIAs can all sometimes mimic seizures. So when we're sure that, or pretty sure that it's not a mimic, that it's actually a seizure, then we try to figure out what type of seizure do we think it is. So what used to be called simple partial and complex partial seizures, that classification went away. And in 2017, the International League Against Epilepsy changed all of the names of seizures. And so now we refer to those as focal onset seizures, either with awareness or impaired awareness. And then we further describe based on the semiology or how the seizure looks. So we talk about motor onset or non-motor onset. And then there's generalized seizures. Generalized seizures are things like absence seizures. Many myoclonic seizures are generalized. Atonic seizures may be generalized. Tonic-clonic seizures may be generalized. And then unknown onset. So if we see a tonic-clonic event, but we're not sure if there was focality at onset, then we would call that an unknown onset type seizure. So when would we do a lumbar puncture? We typically do this if a child is persistently febrile, if they're under or unimmunized, if the child has been pretreated with antibiotics and presents with new onset seizures with fever. If there's a young infant less than 12 months old, they may not show the typical classic signs of meningitis or encephalitis. And so a febrile infant with new onset seizures, we're much more likely to recommend LP for. And any child who generally appears systemically ill, persistently encephalopathic, is not waking up after seizures, or is having multiple or prolonged seizures, then we would strongly consider doing lumbar puncture to rule out any kind of CNS infection as a trigger. When do we image these kids? So the AAN practice parameter that I've referenced here at the side recommends imaging, non-emergent imaging if the child has returned to baseline, and MRI is typically preferred for first-time unprovoked seizures. So what we found based on a series of several studies that have looked at both children and adults is that we can find some sort of imaging abnormality in up to about a third of children with first-time unprovoked seizure. Most of the time, though, it's something like gliosis, which is scarring, or some type of cortical malformation, or gray matter heterotopia, or something that does not require urgent management. Things that require urgent management typically come along with other signs and symptoms. They're not returning to baseline, they're persistently encephalopathic, they have new persistent focal deficits. And so in those children who have those types of symptoms, we would recommend urgent imaging and typically would start with CT because it's quick, easy to get. These would be some of the things that we're looking for, things like hemorrhage, stroke, cerebral edema, mass effect, hydrocephalus, things that need to be kind of treated and managed pretty urgently. If the imaging is done non-urgently or non-emergently, what we do here is we do MRI. And the reason for doing that is mostly to help with prognosis and ideas about long-term management. If there's any kind of focal onset, it's a very young child, unexplained exam abnormality, then we're much more likely to recommend the imaging. So just to kind of compare how good is CT versus MRI, because many places have CT immediately available, and getting an MRI may take quite a long time. The other downside about MRI is that children often have to be sedated because they need to lay still for about an hour during the test, and many young children can't do that. And so this study from 2013 looked at CT versus MRI for first-time seizure evaluation. It included some pediatric patients, but starting at age 14. So this was not our young kids. And this included about 1,000 patients. And what they found, which was consistent with kind of the other literature, is that about 1/3 of them had some type of epileptogenic lesion on neuroimaging. And of the patients with a normal CT, about 12% had an abnormal MRI. So about 12% of the time, the MRI was abnormal when the CT was normal. And typically, when that happened, it detected subtle things like cavernous malformations of cortical development, so-called small cortical dysplasias or mesiotemporal sclerosis. There are small tumors that were picked up in 7 of the patients who had a normal CT. A small tumor was identified on MRI. So there is a better yield with MRI, and of course, we don't have the radiation exposure as well. So our practice is if the patient has first-time unprovoked seizure, has returned to baseline, they typically do not get imaging in the emergency room. We would typically do an outpatient MRI. So EEG, we also recommend when there's a first-time unprovoked seizure. And the reason for this is because it helps us predict how likely it is for seizures to recur, and it would help us identify an epilepsy syndrome if there was one. And so what we know is that epileptiform discharges are more predictive of seizure recurrence. So about 54% of people with an abnormal EEG have recurrent seizures versus only about 25% with a normal EEG. And that's within the first year or so. And those numbers change slightly over time. But generally, normal EEG following a seizure is associated with a lower risk of seizure recurrence. Things that we can do to increase the yield of our EEG are things like hyperventilation, photic stimulation, having the patient sleep during the study. That transition from wake to sleep is associated with a higher yield of abnormalities. We know that the EEG is more likely to be abnormal if we do it within 24 hours of the seizure. So we're more likely to see epileptiform abnormalities and also to see areas of focal slowing. That slowing may be transient, and so that's just something to keep in mind. And then we may see an epilepsy syndrome. So I know this is hard to see, but I put the citation on here so that if you're interested in learning more about all of the epilepsy syndromes in childhood, this is a really nice list that kind of breaks it down by age, when you would expect to see different epilepsy syndromes emerge and things like that. We're not going to have time to talk about all of these, but I'm going to hit on a few of them. So again, we talked about epilepsy is when you have an epilepsy syndrome or recurrent seizures. So how do we treat epilepsy? First line is medications, and we have to choose the medication kind of based on the seizure type and if there's an epilepsy syndrome. So we know that kids earlier somebody mentioned absence epilepsy. So there are very specific medications that kids with absence epilepsy respond to. The 3 that were studied, there was a head-to-head trial that looked at management of absence epilepsy from 2010 by Traci. It looked at ethosuximide, valproic acid, and lamotrigine. And what it found was that ethosuximide and valproic acid were the 2 most effective anti-seizure medications, and valproic acid had the higher, had more likelihood of side effects. And so ethosuximide is recommended as our first line standard therapy. There's also been some literature to suggest that there may be kind of a neuroprotective effect of ethosuximide, and children who are started on ethosuximide over valproic acid may have a higher likelihood of long-term remission from absence seizures. There's just kind of some preliminary evidence for that. So it looks like it may be disease modifying in some way. And we also know that things like carbamazepine, oxcarbazepine, lacosamide, the more traditionally focal medications, can worsen absence epilepsy. And so that's important to keep in mind too. We also have to, when we're treating epilepsy, so we have to think about medication, but we also have to think more holistically about the patient, because many of these patients have other comorbidities that go right along hand in hand with the epilepsy. Some of the most common things that we see together with epilepsy, we can see learning difficulties, developmental delays, ADHD, social skill impairments, including autism. And definitely mood symptoms. So there's a much higher risk for things like anxiety, depression, higher risk of suicidal ideation. And so we have to kind of keep all of these things in mind, especially as we're choosing medications, because we know that some of our medications can worsen some of these things, particularly the mood symptoms. Here's just kind of a schematic or a diagram of multiple seizure medications that we have. We don't have time to go through all of them. And, you know, since this diagram was made, there are more even than this. But we have a lot of choices, a lot of medications we can choose from to manage epilepsy. And so we just need to figure out the seizure type, the epilepsy syndrome, to help select which medication would be best for that patient. So along the terms of finding the right medications, we talked about childhood absence epilepsy and ethosuximide, valproic acid, and lamotrigine. Infantile spasms is another example, another nice example of this. The 3 first-line medications are ACTH, vigabatrin, and prednisolone. We know that the response rate to other anti-seizure medications is extremely low. And with infantile spasms, it's associated with an epileptic encephalopathy that causes a progressive neurocognitive regression or decline in many cases. And we know that the earlier we get remission of spasms, the better their developmental outcome tends to be. And so starting with first-line therapies is important in those cases. We also have to think about other health conditions. So if a person is of childbearing age and it's a female especially, I would be really hesitant about using valproic acid or topiramate, some of the ones with the higher risks for teratogenicity, if possible. I would try to choose something else. We've got to think about their other medication interactions, other organ systems. So if the person has already renal disease or kidney stones, I would avoid things like topiramate or zonisamide, which can cause kidney stones in about 5% of patients. If the patient has migraine, I may choose one of those things like topiramate or valproic acid to help manage both the seizures and the headaches. And then depression is something that we see very, very commonly. About 40% of people or more with epilepsy have some type of depression or mood disorder. And so starting them on a medication like lamotrigine or valproic acid or oxcarbazepine, all of those tend to be more mood stabilizing. And so those can be really helpful to kind of manage the comorbidities right along together with the seizures. So what happens when medications don't work? And our cases will address some of this, but basically we had talked about before, 2/3 of people will have their seizures controlled with the first or second well-chosen medication. That leaves about 1/3 who will continue to have seizures, and we call those people medically refractory or having drug-resistant epilepsy. Some of this data is from the Kwan and Brody studies. So there are 2 main studies, but others have been done also that kind of support these numbers in this data. But when they looked at the effectiveness of the first anti-epileptic medication in almost 500 patients with newly diagnosed untreated epilepsy, and some were children, but most were adults, they found that about 50% were seizure-free with the first medication. That went up to about 64% with subsequent drugs, but the rate dropped with each subsequent medication. And so what their follow-up study showed, their 30-year longitudinal cohort study showed, was that once we get to the 3rd or the 4th or the 5th medication, our likelihood of becoming seizure-free with additional medications really is less than 5%. And so at that point, we're medically refractory, and we have to start thinking about, is there anything else that we can do to help stop these seizures outside of medications? And so one of the things that we think about at that point is we revisit our differential diagnosis and make sure, is this correct? And so one of the ways that we do that is we bring them to the EMU, the epilepsy monitoring unit, to do an overnight EEG for about 5 days, typically without medications. And we try to capture their spells and make sure that, yes, they're having seizures. And we try to figure out where are the seizures coming from. And then we think about looking at the medications that they've been on. Are the medications appropriate for their seizure types? We ask them a lot of questions about medication adherence. We may look at random drug levels, pill counts, take a history of, are they missing doses of medications? Because if they're not taking the medicine and they're having seizures, then that's not really medically refractory epilepsy at that point. And then we typically repeat imaging. So our phase 1 pre-surgical evaluation, which we'll talk about in some of the upcoming case presentations, would involve typically repeating a brain MRI. If they have not had genetic testing, doing genetic testing to try to figure out the etiology of the epilepsy, if it's not clear from imaging. And then we have other imaging modalities that we'll talk about, like PET scan, SPECT scan, and MEG, to try to identify the area of seizure onset, in addition to that 5-day EEG. So here is a case, and this is going to be another quick video. So watch this one. He just abruptly falls in one more time. Perfect. All right. Anybody know what type of seizure that is? And if you don't, that's okay. If you want to just type in the chat what you saw, that would also be great. All right, not getting a whole lot. That's okay. I'm going to play it one last time. This child is standing by the bedside tray, and abruptly head drops, so head nods, and he drops to the ground. So this was a 3-year-old child who was previously developmentally normal, but had a history of febrile seizures, and now he has had an abrupt onset of myoclonic seizures, atonic seizures, and generalized tonic-clonic seizures. So what you just saw there was an atonic seizure. He abruptly lost tone and dropped to the ground. You could see in the video that he was wearing a helmet. So in kids who have atonic seizures, we often prescribe a soft, squishy helmet to protect their heads because they can drop at any time. And so his parents noted, excellent. So somebody noted Dravet syndrome. That's a good thought. Somebody noted atonic seizure. So thank you very much for participating. That's great. So his exam was notable also for ataxia, and family noted that seizures were more common when fasting. So what kind of workup would you guys recommend?
I think the ataxia is concerning. You would want imaging if possible.
Absolutely. Yeah, that's right. Okay, so his imaging was normal. We did an EEG, and so this is what we saw. So just to kind of orient people, anything with an odd number at the end is left side. So this is all the left side of his brain. This is the midline, and this is all the right side on the bottom in the yellow. I'm not sure if you can see my arrow, but what this child has is this child has bursts of slowing, biparietal slowing. And at the bottom image, you can see that he has bursts of spike wave activity that come more commonly when he's fasting. And so his MRI was normal, but we did genetic testing and found a pathogenic variant of SLC2A1. So we'll talk about that. So this child has an epilepsy syndrome, and the epilepsy syndrome is epilepsy with myoclonic atonic seizures. And these seizures typically start around early school periods, so preschool age, 2 to 6 years of age. And these kids tend to have kind of an explosive onset of generalized seizure types. They can have absence seizures where they just stare off. They can have febrile seizures. About a quarter of them will have a prior history of febrile seizures. They can have atonic seizures like you saw in the video where they just drop. They can have myoclonic seizures, generalized tonic-clonic, and non-convulsive status epilepticus. So they should not have focal seizures. That would kind of be very unusual for this generalized epilepsy syndrome. And what we typically see is that they often have a pretty normal development up until the time that they start having seizures. And then we kind of see this plateau or even a little bit of regression when they have lots of seizures. So these kids are almost all initially drug resistant. Medications just don't seem to help very much. But the good news is about 2/3 of them eventually outgrow this and may become seizure free. We often see the comorbidities of things like ADHD type symptoms, executive dysfunction, behavior problems, sleep difficulties, ataxia may happen, and about 5% are due to this genetic syndrome called glucose transport 1 deficiency syndrome. And what that is that is a condition where the body cannot effectively transport glucose through the blood-brain barrier to reach the CNS space. And so what happens with those kids is they get, it's a spectrum. And so many kids will have movement disorder that's induced by fasting. Many will have multiple different seizure types. Some can have refractory absence seizures. Some can have this epilepsy syndrome, epilepsy with myoclonic atonic seizures. The MRI is typically normal, and the EEG that we saw was pretty characteristic for this syndrome itself. Other genes can also cause this epilepsy syndrome. It's not just the SLC2A1. A lot of times it's a complex polygenic inheritance, which means that if we do an epilepsy panel, we don't find a single gene that's abnormal. Yes, you're right. Dosay syndrome or Deuce syndrome, however you say that one, yes, is now called this, EMATS, yes. And so other pathogenic variants, SCN1A, SCN1B, SCN2A, and CHD2 can also cause this. So treatment, again, we mentioned typically these kids are medically refractory, but we start with the broad spectrum medicines. So again, we would want to avoid things like carbamazepine, oxcarbazepine, which could make these seizure types worse. We would start with things like valproic acid, levetiracetam, lamotrigine, ethosuximide, topiramate, clobazam, rufinamide, felbamate. Often these kids are on several different anti-seizure medications, and we often do not see seizure freedom. But the ketogenic diet can be extremely helpful, especially for the glucose 1 transporter deficiency syndrome children. And so, so this is one epilepsy syndrome that has kind of that unique type of treatment option, which is pretty good. So like we talked about, SLC2A1 encodes the glucose transporter, and we can see kind of a spectrum of presentation. Some kids, every kid presents a little bit differently. Not every kid would have that epilepsy syndrome. And so just to cover a little bit about the ketogenic diet. So we always consider if a child would benefit from ketogenic diet if they have medically refractory epilepsy. And what our typical response rate is for all comers with medically refractory epilepsy, if we can get them into ketosis and they can adhere with the diet, is that about 50% of the kids will have about a 50% reduction in seizures. There are certain syndromes, though. This is one of them, the glucose 1 transporter deficiency syndrome and pyruvate dehydrogenase deficiency, that ketogenic diet is actually considered first-line therapy because it bypasses the metabolic pathway that's causing those seizures in that syndrome. Epilepsy with myoclonic atonic seizures, the syndrome that this child had, is also a great time to use the ketogenic diet. We use it for infantile spasms, tuberous sclerosis, kids with medically refractory epilepsy who have gastrostomy tubes. It's much, much easier to use the diet because we have a formula that we can switch over to. The diet is not palatable. It's very, very high fat diet, and kids are very restricted in the amount of sugar and carbohydrates that they're allowed to have. And so it's very, very difficult for a child who chooses his or her own food to comply with this diet. And so it's much easier in kids with G tubes. We also sometimes use it in Dravet syndrome. And these are small, but you will have access to my slides at the end. I'll send a PDF of this because I think the presentation itself is too large, but I'll send it as a PDF so that if you're interested, you can look at these references and see kind of some of the indications for ketogenic diet. So how does it work? We think it works by shifting the body from using primarily carbohydrates to lipids as the primary source of energy. So as the body feels that it's deprived of carbohydrates, it goes into like a starvation mode, produces ketones, and then those ketones can bypass the metabolic defect and provide an alternative fuel for the developing brain. We think it has effects of balancing out the neurotransmitters to make seizures less likely to happen. But we know because of the way that it works that in disorders of fat metabolism, we can't use it. It'll make those worse. And so we have a list of those here. And this is from Dr. Kossoff's paper about optimal clinical management of children receiving dietary therapies. So that's there on the side. So just to kind of look at what does the classic ketogenic diet look like, we typically talk about it in terms of ratios, and that's ratios of fat to carbohydrate plus protein. And so typically the ratio of fat to others is 4:1. So very, very little carbohydrates. Carbohydrates are kind of the yellow wedge, and then protein is kind of the red wedge, red wedge. So that would mean things like rice, pasta, bread, sugary things are almost pretty much not acceptable within the ketogenic diet because of the number of carbohydrates that they're allowed to have. And they instead have a lot of very high fat meats and things like heavy whipping cream, butter, oil, things like that. Some of the side effects, so we work very closely with our dietitians to make sure that they're getting enough of the vitamins and minerals that they need because they have to be very careful about portion sizes of things like fruits and vegetables. And so they often are supplemented with a multivitamin. And then the most common side effects are GI upset, things like vomiting, reflux, constipation, kidney stones, high cholesterol we can see most commonly initially, and that tends to level out over time. They can also develop a risk for fractures and osteoporosis, and their growth trajectory can be slowed, and so we have to very closely follow weight and growth. All right, moving on to the next case. Yeah, so thank you. So there was a question in there about modified Atkins diet. So modified Atkins diet is kind of the second curve here, or the second graph here. And so this typically allows a little bit more carbohydrate in the diet. So it's a little bit easier for children to follow, and we tend to still have great responses with that. For glucose 1 transporter deficiency syndrome, we prefer straight keto if we can at a 3:1 or 4:1 ratio when the child is young and developing. But as they get older, a lot of times we can loosen it to things like modified Atkins. And typically for modified Atkins diet, they, depending on the child's size and all that stuff, the number of carbs that they're often allowed to have is still very restricted, like in the 20 to 30 gram range from the kids that I have seen. But again, that's calculated a little bit differently for each child and their size and things like that. But that's a great thought. Okay, so this is the next case. So the patient's face is blurred just for privacy. So this is the seizure. Her head is just slumping down. and she's unresponsive right at that point. So I'm going to play that one more time. It's kind of subtle. Here she's interacting, she's reaching for something, and then the seizure begins, and she just slumps forward. Sometimes this one didn't show it, but sometimes she has some myoclonic jerks with that. So that looks less abrupt than the child who was having the atonic seizure. This kid, if you saw her face, was having staring, behavior arrest, and she just kind of slumped forward, slowly slumped forward. If she was standing up, she would fall down. And so this child, this is a 10-year-old girl with Lennox-Gastaut syndrome, which we'll talk about what that is. And she has a history of global developmental delay, autism. She's nonverbal. She ambulates with a walker. And she's had developmental regressions since she developed atonic seizures. And so she also has those falling events, but she also has atypical absence with loss of tone as well. She's been on multiple different medications and she failed those. Her MRI was negative. She's had a very extensive genetic workup that failed to tell us the etiology. And she's already had a vagus nerve stimulator placed at an outside hospital that unfortunately did not work too well for her. Just to kind of give some background about this epilepsy syndrome. So Lennox-Gastaut is a developmental epileptic encephalopathy that typically affects school-age children. So again, 18 months to up to 8 years. Can go later. We can see it later, but typically most commonly peaks around 3 to 5 years of age. These people tend to have multiple types of seizures that are drug resistant. Tonic seizures are kind of the characteristic type, and these typically happen in sleep. So tonic means full body stiffening seizures that tend to be pretty short, but they tend to also have a variety of other types of seizures. And LGS or Lennox-Gastaut is very highly associated with cognitive and behavioral impairments, moderate intellectual disability. And then on EEG, we tend to see slow spike wave and fast activity. So this is some information about vagus nerve stimulator. So vagus nerve stimulator is a little device that sits typically on the left side of the chest, and there's a wire that tunnels underneath the skin and goes up to the vagus nerve. There are electrodes placed along the vagus nerve, and little pulses of electricity are sent through the vagus nerve. Typically, the most common settings are that it turns on for about 30 seconds every 5 minutes, and just gives a little pulse of electricity there. When the patient comes into clinic, we have a tablet that looks like this and a wand, and we put the wand over that device and we can interrogate it and we can change the settings and things like that. What we tend to see is that there is an improvement of seizure control over time as this is implanted, but typically we do not see an immediate response. What we hope for is about a 50% reduction in seizures in about 50% of patients. So it can help, but patients certainly, it's called a palliative option because patients certainly are not expected to become seizure-free or come off of their seizure medications, but sometimes it can help. So this is a little bit of thought about how it helps, and this was a slide from the VNS company LivaNova, but basically it shows that stimulation basically works by affecting the nucleus tractus solitarius in the brainstem, and over time we think it works by increasing cortical inhibition to reduce seizures overall. So when she came in, she already had that vagus nerve stimulator. It wasn't working. She was regressing and she was having frequent falls. Her EEG, we admitted her for a 5-day EEG to capture seizures. And during that time, we saw features of Lennox-Gastaut on her EEG. We saw multiple atypical absent seizures, myoclonic absent seizures, and atonic events. Her MRI had no lesion. And so we recommended to do a corpus callosotomy. So this is some outcome data from Children's Hospital of Michigan that looked at corpus callosotomy for seizure reduction. So what corpus callosotomy practically is you have a middle tissue bridge between the two halves of the brain, and the surgeon goes in and cuts that middle tissue bridge, and that prevents a seizure from propagating across the whole brain at once, and so can be very effective for reducing generalized seizure types. And so we see it We use it most commonly for kids with atonic seizures, where over 80% may have at least a 50% seizure reduction. So again, this is a palliative option. We do not expect it to stop all seizures, and it's not effective for focal seizures. So focal seizures can continue. It just makes it less likely that that will spread and propagate to a generalized seizure type. And so here are her MRI images after the surgery, and you can see kind of the split along the corpus callosum. And she did great. So she is now almost 6 months post-surgery. She's having very, very few seizures, and this procedure eliminated all of her atonic drop attacks. And so where she was regressing before and she was no longer able to ambulate with her walker safely and things like that, she's now back up around on the move. And so her parents are thrilled. And she did not have any deficits from the surgery. This is another case. So this child has, starts with just kind of this funny tremoring, and then the child will develop kind of this hemiclonic jerking of the leg. And if they try to hold it down, the jerking continues. There it goes. Okay. So this is a 6-month-old who presented with these hemiclonic jerking episodes. She also had focal status epilepticus with fever. Her brain MRI was normal, and her ictal EEG was normal, and she was developmentally normal. We don't have much time, so I'm going to hold off on commenting, but somebody earlier had mentioned Dravet syndrome, and this is a classic presentation of Dravet syndrome. So this is what we tend to expect to see. So workup, diagnosis, medications to avoid. So Dravet syndrome is another epilepsy syndrome of childhood. It's a severe myoclonic epilepsy of infancy associated with an epileptic encephalopathy. And the most common cause, although there are others, is this SCN1A pathogenic variant. So it's a sodium channel mutation that causes this syndrome most commonly. And it's typically associated with refractory epilepsy and neurodevelopmental problems. And so what we typically see is that a child is healthy and normally developing until they start to develop these hemiclonic seizures. The hemiclonic seizures can turn into like a focal status epilepticus, especially in the setting of fever or illness. And because their EEG is normal, they often look normal. Initially, they are typically diagnosed with febrile seizures. But when febrile seizures are prolonged, and especially if they're focal and occurring before 1 year of age, you always have to think about this. Over time, they develop multiple seizure types with and without fever. So it's a progressive myoclonic epilepsy. They typically have absence and atypical absence seizures. They have generalized full body shaking seizures, focal motor and tonic seizures. And some of their triggers include heat. And so if they're overheated, if they're put in a warm bath, if they're really excited or see contrasting visual patterns, then those can all trigger seizures. And they tend to have a neurodevelopmental plateau that begins around the time of the seizures. They also, over time, typically develop ataxia, difficulty walking, kind of a crouched gait posture, especially as they get older. And these children almost always have pretty significant behavior problems, hyperactivity, autistic traits, and aggression. So the MRI and EEG are usually initially normal. The EEG becomes abnormal typically with time. And we commonly see a family history of febrile seizures or epilepsy, but not everybody with the exact same mutation in the family presents exactly the same way. So we see this spectrum of how other people present. And probably that's because of other modifying genes and environmental factors that make some people present differently than others. The most common treatments that we would use first line would be things like valproic acid, clobazam, topiramate, levetiracetam. There are now some new FDA-approved medications, stiripentol, fenfluramine, and Epidiolex. Epidiolex is CBD. And what we know, and one of the important things for you guys to recognize, is if a child presents this way, although their seizures look focal, carbamazepine, oxcarbazepine, lamotrigine, lacosamide, the sodium channel type medications medications make these worse and can precipitate more seizures and status sometimes in these kids. So those are definitely medications to avoid. Sometimes we use ketogenic diet. Here is a diagram from epilepsia that talks about kind of when to consider different medications and which medications may be helpful in these children. Do we have time for more cases? I included a lot of cases in case we have time, but I'm not sure how we're doing on time.
Yeah, thank you, Dr. Weber. This is fascinating. We are at the hour. I can certainly open up and see if, I know it's the afternoon for our participants, and I don't know if they have other clinical duties. Would you like to do one more case? If you,
Sure.
anybody, yeah, we'll try. If anybody has questions and needs to leave shortly, please feel free to type it in the chat box. I can always monitor that while Dr. Weber's speaking and interrupt her if needed. Thank you.
Thanks. Okay. So this fourth case is a 3-year-old who presented with focal impaired awareness seizures. And so again, this would have been complex partial seizures before. And her seizure semiology, she starts with staring, kind of wide eyes, dazed look, lip smacking. So oral automatisms are things like lip smacking, pulling the right side of her face. So the right side of her face kind of contorts and pulls and sometimes jerks. And she's already failed 4 medications by the time that she's come to us. So she's still having lots of seizures. So her MRI shows this focal hypointense wedge-shaped lesion in the left side of her brain in the temporal region. And in the second picture on the right, I'm not sure if you can see my arrow, but there's kind of a bright signal that extends to the ventricle. And so that's what we call kind of like a tail. And so that's highly suggestive of a cortical dysplasia, but the differential would be something like a low-grade tumor. So this child had a PET scan as part of her evaluation. And what this shows, a PET scan is a glucose uptake scan. And so this looks at cerebral metabolism, with the thought being that most of the time in between seizures, so an interictal PET scan, we expect to see hypometabolism, or more of the darker, more of like the blues and purples in an area of the brain that's sick and that's not using glucose well. And so what we see is that there is an asymmetry in the temporal lobes. And so her left temporal lobe is hypometabolic. Okay, and that showed that. And so we always do an EEG kind of right up until the scan to make sure that they have not had seizures, because that will kind of influence the results. Her EEG is shown here, and kind of along the middle part, the F7, T3, T5, that area is slow and has focal spikes. And then her seizure kind of had a mid-temporal T3 onset. And you can see just kind of a line of spikes across the middle of the screen. So we captured multiple seizures. So what we went on to do with her was, after the phase 1, the PET scan and the MRI and the EEG, and we captured seizures, everything kind of was in agreement that seizures were coming from the left temporal lobe. And she had a lesion there, the PET was abnormal there, and the EEG was abnormal there. And so she went on to have a phase 2, and a phase 2 is a stereo EEG, where they surgically implant needle electrodes into different parts of the brain. And the reason they do that is for a couple of things, but they can identify with more clarity the exact area of seizure onset. So where the seizures are starting, where the network is, where those seizures are propagating. And they can also do mapping. And so mapping is where they put a little bit of electricity through these electrodes to try to localize where is language. So being on the left side in the temporal lobe, most people have at least some language function in their dominant hemisphere there. And so we needed to figure out, was her seizure onset zone overlying the eloquent area? Or if we did a resection, would we significantly impact her language and speech? So this is a different child who had a stereo EEG, but this is kind of a 3D reconstruction of how these stereo EEG electrodes can look. And so we have multiple contacts. So each of these little beads is a different EEG contact, and we can watch the electricity kind of at all of those points in the brain to try to figure out where seizures are coming from. And then we can map from all of those points as well. And so she ended up undergoing a temporal lobectomy, and she had that cortical dysplasia and the area of seizure onset zone, kind of, which was perilesional, resected. And now she's been seizure free for 2 years. So she's done really, really well. Parents told me that since she had this done, her language and developmental skills have also just skyrocketed. She's doing tremendously better after this surgery because they've controlled the seizures. So that was a really, really good outcome, and just kind of another example of how, how we can treat some of these medically refractory kids. Just kind of as a follow-up to this, I have just a couple more slides about other types of imaging that we can use. We did not in her case. There's something called SPECT scan. SPECT scan is single photon emission computed tomography. Much easier to just say SPECT. What this is a nuclear medicine study that looks at regional blood flow. And so what we do is we compare the regional blood flow to different parts of the brain at seizure onset, and also when seizures are not occurring. So at a resting state and then at seizure onset. And so the way this is practically done is a patient comes into our epilepsy monitoring unit. We wean them off of medications. A tech sits at their bedside and watches the EEG screen and watches the patient. And as soon as the seizure is starting, they inject a radio tracer that goes in and kind of tags the area of maximal blood flow at the time of seizure onset. And then we combine that or compare it to the interictal SPECT. So here's an example where you can see A, or the left side, is the ictal SPECT and B is the interictal SPECT. And so we can see an area of hyperperfusion or increased blood flow in the left frontal lobe at the time of seizure onset. And so in kids who have non-specific MRIs, kind of a diffuse appearing EEG, we can't really localize really well. This gives us another data point to help tell us which side is the seizure starting on, exactly where it's starting. And frontal lobe cases are tough because a lot of times we don't see a whole lot of great localizing features on the EEG at the time of seizure onset. So this can be really helpful. MEG is another thing that we can use. So MEG combines EEG data with structural imaging. And so this is kind of like a magnetic source imaging to look at dipoles on the head. And so this is an example of how that might look. And so this was a case of a 10-year-old with refractory epilepsy. The video EEG suggested that her seizures arose from the right side of the brain, but the MRI showed multiple left-sided lesions. The FDG PET showed bilateral abnormalities. So we didn't have a great, this was a Cleveland Clinic case study that the data did not have a great localization or a great hypothesis about where this would be. So they did the MEG to look at the interictal epileptiform discharges and the dipole of those, and they could see that localized to the right side of the brain. And then they went back and looked at the MRI, and they saw a very subtle hyperintensity in that same area where the MEG identified that the epileptiform discharges were coming from. They resected that, and then the patient became seizure free. So MEG can sometimes be helpful too. We don't use it in every case, but in certain cases it can be helpful to guide us. So I will stop here unless if there are questions. I'm happy to answer some questions.
Thank you so much. That was, as you said, that could have been several lectures. It's such a vast topic, and I like all the updates. I think it's helpful to have the videos and the cases. I know from a primary care standpoint, we get these types of concerns from parents all the time, and it is hard to sort out who we refer to you and who is more of a reassuring, pseudo seizure or something benign. So that is very, very helpful. that is a lot of information. I'm sure that there are some questions. I'm not sure if anybody has time to ask them now, but you can feel free to, if you're not able to unmute yourself, type into the Q&A box or the chat, and we could, answer them for you. If not now, I can circle back with Dr. Weber via email here at Nationwide Children's and get those answered for you. Yes, do please fill out the evaluations. That's always helpful. We're so grateful for your time and your expertise, Dr. Weber. Feel free, though, if there's any cases that you've had or comments on management of things that you see and do, we're very happy to hear back from you.
Thank you very much.
Yeah, no, thank you. That was awesome. Any questions, folks?
Hello, this is Peter once again. Thank you very much, Dr. Amanda, and thank you, Professor Downs, and the rest of the facilitators. This is Peter from Uganda, that is representing the team that is being mentored by Dr. Downs. Basically, my question is, one is epilepsy, can it be cured? And if it resolves, up to what period do we stop the medications? And also, we operate in Uganda that has a limited range of resources and especially medicines. So when it comes to some medications, like in circumstances maybe of pregnancy, which medications do we recommend?
Question. So there's a lot there. So I think I think he broke up.
Yeah, thanks, Peter. You can mute now so you can hear your answer better.
Yes, hello. Can I continue?
I think let her
Sure,
answer
please,
that one
go ahead.
first,
Yep,
Peter.
I think it just broke up. Yep.
Okay. I hope I was heard in the first instance. I was saying that in Uganda we operate under a limited range of resources, and most of the times we, like for management of epilepsy, it is clinically diagnosed, and even investigations like MRI, EEG, CT scans. Our patients do not manage some of them, so we do much more of clinical monitoring. And I was saying that one, would you help us to go through some of the recommended drugs that we can use for epilepsy in pregnancy? And then number two is, at what extent can a drug help patients with epilepsy? And also about the prognosis, that can it be cured? And if it is resolved, for how long do we continue with the treatment until we are very sure that it has resolved? Maybe is it 2-3 years, or 5 years? And is there a possibility of it reoccurring again? And also during our management, because we have common drugs like carbamazepine, phenobarbital, we use some of this because of the costs that are a bit affordable for our people. Whenever we use carbamazepine, we combine it with the folic acid. Is it recommended? Do you think it is okay, or we could do consider discontinuing it? Then another question is, if one is able to live without seizures, if he knows his or her triggers, is that reason enough to maybe for some time to say that he can stop the treatment? for life? Thank you.
You're welcome. Yeah, so there's a lot of questions there, and I think I'm gonna have trouble answering them in a great way. So first of all, I'm a pediatric neurologist, and so when patients are pregnant, I don't manage them. And so what I know about epilepsy and pregnancy is a little bit limited from that perspective. There are epilepsy pregnancy registries that I can send you guys information about, but what that's doing is that is collecting data from pregnant mothers who have epilepsy and who are on anti-seizure medications, and it's collecting long-term data about the safety for the fetus. And so you're absolutely right. Any woman who is of childbearing age who has the potential to get pregnant while on an anti-seizure medication, regardless of which medication they're on, you're right, we always start folic acid, and we typically recommend a higher dose of folic acid. So people who don't have epilepsy typically take 400 to 800 micrograms. We recommend 1,000 or even 4,000 micrograms, and this is mainly to prevent the neural tube defects that can happen as a result of exposure to some of the anti-seizure medications. So that's a really important point. Some of the medications in pregnancy that we know are more potentially harmful. Probably one of the ones that we have the most data about is valproic acid or Depakote. So valproic acid is associated with a wide range of potential complications in pregnancy. And so if possible, if your patient can tolerate a different medication, and if they can come off of Depakote or be on a lower dose of Depakote, then that is preferable to prevent those teratogenic effects. The medications that we most commonly use, if the patient's seizures are fairly well controlled, the ones that we prefer to use during pregnancy are things like levetiracetam, which is Keppra, and lamotrigine, which is Lamictal, and I'm not sure if you have access to those or not. But if you have questions about kind of the risks related to each medications, I think looking specifically at that pregnancy registry data would be really helpful to help you choose and to help mom kind of choose, the risks and benefits of the medication, and things like that. So in terms of which medications to use, I think that really depends on the epilepsy syndrome and seizure type. And so that's why I was trying to emphasize that in my talk. So we know that focal epilepsy tend to respond very well to carbamazepine, oxcarbazepine, lamotrigine. Those tend to be kind of the medications that I would recommend to start with in a focal epilepsy. The caveat to that, though, is that if they have a history of febrile seizures and multiple people in the family have febrile seizures, I would be more hesitant because these Dravet syndrome kids, the sodium channel mutations, these GEFS plus spectrum kids can look focal, but actually starting a medication, a sodium channel medication, can actually make them worse. So in a child, I would be a little bit more careful about that, especially with strong family history of febrile seizures in him or herself and also in the family. But for different epilepsy syndromes, different medications are the best. So for example, infantile spasms, we know the 3 drugs of choice are prednisolone, ACTH, vigabatrin. If you have access to those, prednisolone is probably the one that I would assume has the easiest access for people. But prednisolone is associated with risk for immunosuppression. And so you have to follow those kids pretty closely because they can get pretty sick pretty fast. And so that's one thing there. With absence epilepsy, like I was mentioning, the 3 drugs of choice are ethosuximide, valproic acid, and lamotrigine. Ethosuximide is the one we use most commonly, but if you have access to valproic acid and not ethosuximide, that's the one I would choose there. For many of the generalized epilepsy syndromes, things like juvenile absence epilepsy, juvenile myoclonic epilepsy, valproic acid tends to be extremely effective. The caveat to that is that if you have a young woman who is of childbearing age who has one of those epilepsy syndromes, you have to really weigh what other options you have to try to treat them, knowing that valproic acid tends to be one of the more high-risk medications in pregnancy. And so depending what you have access to, which broad spectrum medications you have access to, I would try to choose something like levetiracetam, lamotrigine, a different broad spectrum medication if you can get away with it in those people specifically. And then if you look at on my presentation, I have information about epilepsydiagnosis.org. That is a website through the International League Against Epilepsy. You have to register for an account, but it's free. And then through that website, it breaks down all of the different epilepsy syndromes by age. And it talks about the common EEG features, MRI features. It has videos of many of the seizure types. And also, along with that, it talks about some of the recommended treatments. And so it really just depends. The medication of choice really just depends on the epilepsy syndrome and seizure type. In terms of how long to continue treatment, what our typical practice is that we try to get a patient seizure-free for 2 years, and then we reevaluate, repeat the EEG. If the EEG has normalized, then we try to wean off of the medication. Children are more likely to grow out of epilepsy or than adults. And so I don't know what the adult literature is. The other thing about adults is that they're typically more reliant on things like driving or, they need to be more functional from a job perspective and things like that. And so having breakthrough seizures can be a lot more disabling for them. And so I think a lot of times in the adult world, and again, I'm not an adult epileptologist, but what I've seen is that in the adult world, there's a lot more hesitation about weaning medications just because the patient needs to remain seizure-free. For the purposes of maintaining a job and things like that. There are some syndromes that we know have a very, very high chance of seizure remission. And those are things like the self-limited epilepsies. So there's a self-limited epilepsy with centrotemporal spikes, which used to be called benign Rolandic epilepsy. And they have very specific EEG features. They have the centrotemporal spikes and the horizontal dipole, and they should have normal MRI imaging or normal imaging of some sort. Those almost everybody with that syndrome outgrows that by the time that they're mid or late adolescence. And then sorry, just lost my train of thought. Oh, and childhood absence epilepsy, at least 2/3 of those kids remit and go on to become seizure-free. And so with them, I would certainly wean the kids with self-limited epilepsy with autonomic features, which used to be called the benign occipital lobe epilepsies. Many of those kids outgrow their syndromes. So if you can identify the epilepsy syndrome, then that can give you a better idea about prognosis. There's also, if the patient has juvenile myoclonic epilepsy or juvenile absence epilepsy, they're much less likely to outgrow that. And so knowing that, and those people tend to have kind of faster frequency spike waves, so like 4 to 6 hertz spike waves. They tend to have, with JME, they tend to have myoclonic seizures. They can have absence and they can have generalized tonic-clonic. And there's a very, very small percentage of those people who can successfully wean from medications, probably less than 20%. And so those tend to be lifelong epilepsy patients. The other thing is patients with lesional epilepsy, so related to cortical dysplasias or things like that. We often have more difficulty weaning them. Especially in the absence of some sort of surgical intervention or something like that, those people are a little bit less likely to wean. There is, and I can send you guys this too, there is a paper that has actually like a prognostic tool that helps you calculate the likelihood of seizure remission in a given patient based on the different, types of features of their epilepsy. And so that may be helpful to answer the specific question, but it is hard, and so a lot of times what I end up doing, it has to be a very, I think, honest conversation with the family about what are the risks if the seizures recur and how much do they want to wean off of the medications and are they adherent to the medications anyways? And if they very much want to be off of the medication, then usually, you know, and they've been seizure free for a year or two, then usually I try to be as supportive as possible to try to help at least guide them through that to see how they do, but just make sure that they have close follow-up in case they do recur and have to go back on medication. Does that make sense?
Yes, thank you so much, Dr. Weber. And yes, and I can communicate more with our Uganda team, your resources, and if they have other questions, can reach out to you. Thank you so much for your time today. Thank you, participants, for being here for this Pediatric Summer Institute session. I know it's a long afternoon for you guys, but it's a lot of great information and good for all of us to have. If there are other questions, I'll be happy to send them to Dr. Weber and or get you those resources. Again, all of these lectures are recorded and will be available later if you want to go back and look at it, and then we can circle back with Dr. Weber. And Dr. Weber, we will get you the evaluations. Thank you again so much for your time. Thank you, everybody, for your time. I hope you have a good afternoon where you are, and that we meet again. Thank you.
Yeah. Bye-bye.
All right. And I